For those of you who are new to this, and I think actually one or two of the faculty are, this is EPICS, Emerging Paradigms in Case Series, focusing on thoracic oncology. It's basically an advisory board, but it's done in a very unique way. We have topics, brief discussions, presentations. We're operating obviously at a very high level here, so we don't go through the background data, but really updates over the last year or two and our unique perspectives. And then a number of questions that are raised about the data, and the discussion is entirely around this table. As the chair, I get texted questions from our wonderful industry colleagues, without whom this would not be possible, and but they stay silent. They just absorb. So it is the unvarnished, unfiltered, unadulterated perspectives on the recent data, which doesn't necessarily happen at more conventional advisory boards. So in terms of just housekeeping, again, minimize the noise level during each talk and discussion time, so please turn off your cell phones, which reminds me I should probably do the same for my own. And does anybody have a pager anymore? I think you can get rid of that, Stephanie, pagers to vibrate mode. I don't know if anybody has a pager. Be courteous to faculty and fellow attendees. If you do get a call, go outside the doors and address it there. Today's syllabus is contained on the iPad at your table. And please feel free to use the iPad during today and tomorrow's sessions. You'll be prompted to enter your email address, and you can take notes on any slide, and your notes as well as the final presentation deck, if you request, will be emailed to you within a few days. Please note that the slide presentations on the iPad may not necessarily coincide with the speaker's presentations if we've either excluded proprietary slides from the submitted presentation or have hidden some. Proceedings from this meeting will be recorded and compiled in an executive summary report that will feature analyses of the key takeaways as well as some audio highlights. So comment to the faculty. I know we tend to get unrestrained at times, but realize that that all of this is being recorded. Full audio will be available, and this report has already been pre-purchased by several companies, including AstraZeneca, Genentech, Lilly, and Pfizer. If you wish to receive a copy of the executive summary report after the program, please stop by the registration desk, and TRM will arrange this. An evaluation form for today's session is available on your iPad, so please note that if you begin the evaluation and then you move back to the presentation, your responses will be lost, so you probably should wait to the end. Certainly wait until all the presentations are conducted to begin and complete the evaluation. So we'll just go around the table briefly, have everybody introduce themselves, and then I'll impersonate Ignacio Estuba and do his talk. MJ?
Okay, I'm Mohammed Jahanzeb, University of Miami. I do lung and breast cancers and medical oncology.
Nasser Hanna, Indiana University. I do mostly thoracic cancer.
Paul Pack, Memorial Sloan Kettering. I do lung cancer with a focus on squamous lung cancer.
Oh, wait there. Can you do
Right lung or left?
Memorial Sloan Kettering.
Marty Edelman, I'm at Fox Chase. When I goof off, I do lung cancer. Otherwise, I do administration.
God help you. So I'm a firm believer in the Peter Principle, Marty, and your role would be one step beyond my competency level. So I know what I can do and what I can't do. So I'm going to start actually with Ignacio's presentation. Obviously, I'm not a pathologist, although we deal with them all the time. Ironically, the one Ignacio is literally could not get in. He's in France, and his flights were completely canceled. So there was just no way he could get here until late tomorrow, essentially. So he did send his slides, though, and I think as we go along, we might want to comment on some of them, because some of what he's written is very MD Anderson-centric, not necessarily true of the rest of the world, but still quite intriguing. So if we can start. And then Marty will follow up with perspectives on prognostic and predictive biomarkers and their clinical and research relevance. So again, here, this is actually altered now. So Greg is not coming until about 4. So Paul and Nasser, you're going to be moving up a notch, if you don't mind. And then we will have dinner at the end locally. So Ignacio's talk, practical issues from the pathologist perspective. This was actually an adaptation of a talk he gave at ESMO during a session there. His disclosures, he's got several companies I haven't even heard of, so I'm always intrigued. I'm not sure what some of these are, but very interesting. So again, from his perspective, tissue sampling, how to maximize utility of limited tissue, which I think is a major challenge for all pathologists. The role of rebiopsies and how they influence treatment decisions. The whole issue of single gene versus sequential versus now almost ubiquitous multiplex testing. Liquid biopsy, which I imagine several other speakers will get into. Looking at the validity, reproducibility, and standardization of these approaches. And finally, the role of PD-L1, the implications of Blueprint Project, as well as other markers of immunoresponse. So again, this is background. We have many different samples that we can get, whether it's surgical samples, which obviously enable us to get a whole lot of tissue for processing, and it's probably the preferred approach if it's possible. Core biopsies, it's sort of interesting. Back in the dark ages, wasn't that long ago, maybe 15, 20 years ago, pathologists were interested in making the diagnosis with as little tissue as possible, because the only question then was small cell or non-small cell. And if they could get by with minimal tissue, all the better. Obvious things have grown incredibly complex since then, and we've completely reversed course. FNAs are totally insufficient for the most part. And ideally, we need cores when we can get them. They're not always available. And then the whole issue of cytologies, liquid specimens, can you create a plug that essentially will have enough cells to interrogate what you have. Again, the whole issue of heterogeneity, and this comes in many different forms, at least from the clinical standpoint. Histology, is it adeno, is it squamous, is it both? The genomic abnormalities, many of which are mutually exclusive. And then markers of immune response in particular, which can be dynamic. PD-L1 expression, I've had a bunch of patients who've gone from 50% to 80% or 50% to 5% on subsequent samples. Is that a true change, or is that just the sampling of the specimen over time? And I think that's something that needs to be determined. And of course, other immune markers, including immune cell infiltrates, immune signatures, TCR sequencing. I think methylation is still a research issue, and doesn't, unless somebody can tell me otherwise, does not yet have any clinical or practical application. So, when is biopsy and genomic testing important? At least in terms of diagnosis, we have to address tissue sample availability and quality. We can sometimes get a huge amount of tissue, but it's fibrotic with lots of stroma, and it's not easy to actually get genomic testing. Is it going to be a core biopsy or a cytology? What kind of molecular tests need to be performed? In our institution now, we order 3 tests, allegedly reflex, although that is in question. PD-L1, a fusion panel for ALK and ROS and NTRK, et cetera, and then a separate molecular panel. They have to be ordered separately. It's not just one gemisch. I don't know. MJ, what's your send out in-house altogether or separate?
We do PDL1 in-house and send out next gen to Foundation.
For all the rest?
Yes.
Nasser?
We do PD-L1, EGFR ALK, ROS1, and BRAF and KRAS in-house. Otherwise, we send out.
To Foundation or some other place?
Foundation for tissue and Guardant for liquid.
Liquid. Paul, everything's in-house, right? Yeah. And do you have to order it as a reflex?
Most of it is reflex except for the next-gen sequencing.
Uh-huh.
So we sort of order that once the initial panel comes back.
So what does the initial panel consist of?
The initial panel now is PD-L1, IHC on every one. There's reflex, EGFR, and ALK testing on lung adenocarcinomas, not on the squames. And that encompasses the reflex part. And then the NGS is ordered.
BRAF is not part of that?
BRAF is not, yes. So BRAF and ROS1, all these things are picked up on NGS.
Okay, so you have to, so essentially you're ordering NGS on basically anybody who's negative for the others.
Essentially, we're ordering NGS on everyone.
Yes.
Yeah.
Marty?
So somewhat in evolution, strangely the PD-L1 goes out because of machinery issues of the different platforms.
So
sort
is
of
it
an
reflex or not?
Theoretically.
So like us, theoretically,
Yeah, because
but
it's
not
all-
always.
The problem with reflex is it sounds great, but then what do? You know, particularly at a referral institution, you know, there's a limit to how much payers are going to pay, and a lot of times, you know, somebody's coming in and they get, you know, is it a rebio, or they've had something and it's a new operation for some reason, or, you know, I mean, where the tissue comes from can be any of several different sources, and so it goes, you know, to pathology, which may or may not have run the initial specimen. So it's actually complex to operationalize that, particularly if, you know, you're depending on a third-party payer.
So is you said you're going NGS, but right now it's still single gene?
Yeah,
or
there's
no?
there's sort of an automatic NGS. So there are some single genes that kind of trickle on back, you know, that come back relatively quickly, like EGFR and ALK, and then
And
with a
PD-L1
bunch of
you do,
PDI
right?
Well, yeah, and again, theoretically, that should come back within 2 days, and then there's a large in-house, I guess it's going to be like 250 genes that's going to come back, but we still have issues with that, and this is, you know, it's become something, you know, where different parts of pathology and different people have different views about what to do, and because the other issue with all of this is tumor mutational burden and how that's going to get calculated. So
You're not doing that in-house?
No, well, you know, again, it's difficult because you would be doing it on a subset of the genes, and the smaller the panel, the less accurate. So that's a complexity, which is if we're going to order that, why not do the whole panel outside? So we have not reached total consensus.
So we do everything in-house, but the sequence that we get things back is sort of difficult. We get PD-L1 back before we get everything else. So of course, it's 80% there's this natural inclination to act on it without knowing what EGFR and ALK are. We'll then get the fusion panel back because that's faster, so that'll have ALK
Yeah,
and
it makes no
ROS1.
sense.
And then later NGS, which contains EGFR. So if you have a high index of suspicion, we have to do separate single gene testing for EGFR. We have an in-house alliance with a number of research projects with Guardant. So we're probably half the patients we're simultaneously sending off liquid biopsy. If we want TMB, we got to send it to Foundation. And we've actually started doing that for selected patients, but that's not a routine thing. The goal has always been to do everything in-house. And we too allegedly have reflex. I'd have to say more than half the time it doesn't happen. So again, just to continue Ignacio's talk, what are the needs of the lab as well as the clinicians? And of course, determining the site to be biopsied. So ideally, if it's a new diagnosis, you want to biopsy the metastatic site. It establishes stage, it establishes diagnosis. When it comes to tissue, and you can get a much better specimen from the primary, then you have this dilemma. Do you do both? Do you just rely on the primary and assume that they have stage 4? So this also creates some controversy, which, to be frank, before the molecular era really didn't exist. In the setting of recurrence or suspected progression, again, determining the optimal lesion to be biopsied. There may be a juicy node, but if it hasn't progressed, that's not what you're going to go after. You want to go after the growing lesion. There's got to be constant communication between the clinicians and the pathologists regarding the purpose of the biopsy and what we're really after, so they don't do extraneous panels. And then, of course, the molecular testing that needs to be performed. So this is very interesting. I emailed Ignacio. I don't think he got back to me. But I think this is what they're doing in-house. It's some sort of paradigm where they're, of course, getting pretreatment biopsies and liquid biopsy. And then, at least in their immunotherapy trials, they're getting repeated liquid biopsies. I think outside of a clinical trial, you wouldn't do that. And then biopsies during treatment, which is problematic from my standpoint, because if they're responding, what are you going to learn? And what are you going to biopsy? If they're progressing, well, you'd want to biopsy then anyway. And certainly that's happening at the end.
Well, I think
So-
looking at his title, it's with trials, so you're
At-
really looking.
At
immunotherapy
MD
trials
Anderson.
at MD
So
Anderson.
does anybody do anything similar?
So, well, we have studies which actually mandate, you know, rebiopsy, you know, at a certain point during that. It's obviously funded by the study to see what exactly happens. And it's kind of fascinating because, you know, we have one trial in particular. We had a patient, you know, rebiopsied a lesion that was, you know, probably pretty much the same size, easily accessible, and and this was with cores, so it wasn't just an a tiny little FNA. It was multiple cores. Went from lots of tumor to lots of white cells. So
it really calls
there
into
may
question
be-
what you're.
There may be value to this as we try to figure out what some of these newer, the immunotherapy combinations are doing. So I think that's the paradigm that he's showing there, and I think it goes along with, many of the.
Well, in the context of immunotherapy trial, you're going to rebiopsy the indicator lesion. What if you think they have pseudoprogression? They popped up with some mediastinal nodes. You're going to go after that. So I'm really curious to know.
But pseudoprogression would be progression, so that would be
Well,
that
but so
criteria.
if you're going to do a rebiopsy, you'd probably preferentially go after that than the
Yeah.
original lesion.
But I
ideally
think this
do
has
both.
to be, even on
Yeah.
clinical trials,
So.
this has to be an optional companion protocol rather than mandating. So
But-
that you tell the patient you can't get this new therapy unless you agree to multiple biopsies.
It's very hard to enforce that. It's frankly very hard to conduct those sorts of trials. So again, their paradigm prioritizing and qualifying for molecular assessment. Other surrogate methodologies, certainly IHC has been used for ALK, although I'm amazed by the number of folks that I've had are ALK positive by IHC and fusion negative. I have at least a couple examples of folks that were started on alectinib based on IHC who did not respond, and later on their fusion came back, and one of whom actually was an EGFR mutant. So we made the rapid switch from alectinib to osimertinib. So I have personal questions about the reproducibility and validity of IHC. Again, multi-panel tests versus single tests, and NGS. So again, this is their diagnostic algorithm in 2018, ideally cytology, biopsy, and blood, with the latter sent to look for circulating free DNA. You can see the various cell types. Apparently at MD Anderson, at least, they do NGS on adeno or NOS, and I imagine adenosquamous, but not on small cell neuroendocrine or squamous. I would think they'd do PD-L1 on at least, well, they're doing it on squamous adeno and not NOS. I'd probably do it on everybody except small cell. I don't know. Is that the...
But NCCN has additional categories of squamous, like squamous in a never smoker or mixed
So
histology.
all adeno regardless of smoking history and all never smokers or minimal remote smokers regardless of histology.
Yes.
That's pretty much what we do. So the advantages of NGS, and again, I've doctored up this slide because I didn't completely agree with it. Provides simultaneous information regarding multiple targeted gene abnormalities, and that's why we use it. Yields data on mutation, copy number variations, indels, and translocations. He wrote that turnaround time is acceptable. I'm not sure that's a uniformly agreed upon. Costs are reduced compared to doing everything in sequence. Clinically, it offers to patients more options, potentially off-label treatment for rare molecular abnormalities, and of course, an opportunity to get onto genomic-based clinical trials. Can also offer information on TMB. It's the only way we can really do it. And immune suppressed genotypes, LKB1, which has sort of emerged over the last couple of years, and can be performed on small tissue samples and, of course, in liquid biopsies as well. So I added this slide. There's still concerns. Turnaround time, with rare exception, is usually 2 weeks. Maybe you guys are better at Memorial Sloan Kettering.
Or
but
worse.
You're worse,
Yeah,
okay.
'cause we also sequence the germline to make the,
Pray tell why?
to make the so instead of inferring it bioinformatically, then we have accurate calls as to what actually is a somatic variant. So it's additional sequencing. That
But
we end
is
up
that,
doing.
how much time does that add?
I don't know for absolute certainty. I can tell you that the average turnaround time is about 4 weeks now to get
Oh,
the results.
ugh.
It's not 2 weeks for the
Yeah,
NGS
sick
panel.
patients can't wait, that's
No,
the
they
problem.
can't.
So,
I would add that maybe 1 out of 10 patients can't wait, at least in my
oh, I
practice.
think 1 out of
Weeks is
3
long
can't
too
wait.
for-
Weeks is
Yeah,
very
that's
long.
way too long.
Remember the.
Even if they can wait physically, they just can't wait
Waiting, yeah.
psychologically. It's a real
That's what
problem.
I tell them, that it's an emotional emergency, not a medical one.
Well, but it's, as they're getting worse, as they're getting more short of breath, it becomes a physical emergency too. For most non-academic centers, this is a send-out to commercial concerns. So again, they have to marshal the tissue. Sometimes that's done elsewhere. So a lot of coordination and cooperation with institutional pathologists. And of course, it doesn't do PD-L1. So you still got to look at that separately. So we use it. Everybody uses it. But you know, there's been talk about instantaneous testing. I'd like to see that. $30 in 30 minutes. Maybe it'll happen in our lifetimes. Moving beyond PD-L1 as a biomarker, and I'm sort of interested in the Memorial perspective here, since Paul, your place is so heavily invested in TMB. But again, looking at immune cell infiltrates, the expression of new targets, gene expression signatures. And so that's from the immune level, and then from the genomic level, MSI, TMB for immune checkpoints, particularly for the combinations of CTLA-4 and PD-1, and then genomic predictors of response, such as STK1 and LKB, and then genes involved in the activation of the interferon gamma pathway.
Is it not STK11?
So, yeah, I think he lost a
He lost a one.
one there.
Yeah.
I
With the
apologize.
deletion.
It's an extra deletion.
Listen on.
And then the JAK gene, we're actually doing a study combining Pembro with a JAK inhibitor frontline and 50% or higher. So TMB at Memorial, done in-house, it's sent to Foundation?
Yeah,
How does it work?
It's done in-house. It comes back on our impact report now formally. Even before that, it was sort of one mutation, was like one mutation per megabase, but we get it formally calculated now.
So it's done as part of the reflex, or you have to order it?
It's part of the NGS panel, which we still order.
Which you still order,
we
and
get
how,
it reflected.
so it still takes upwards of a month to get back?
That's right.
Which
And
is
so
a
for that
selection
first
bias
slide,
right
yes,
there.
That's right.
Anybody else routinely doing TMB?
But it's part of the report when I get Foundation.
Well, when you get Foundation,
Yeah.
but you're not going out of your way to order it.
No.
Nasser? No.
No, and I think the question is, you know, so what is the potential value of TMB? Would this persuade you to give somebody Nivo-Ipi first line, for instance, if they had high TMB? If a patient has PD-L1 less than 1%, and you're considering what therapy to give them, would TMB high versus low, you know, persuade you one way or another? So I guess that's even the larger question is, you know, are we getting TMB, but then what will we do with that?
The question is, are we acting on it beyond a research study? Marty?
No, I agree. I think right now, you know, though it sounds good, I think, you know, if you look at the guy who was the discussant, I think at the AACR, or this
Dave
sort
Rim
of,
from
first came
Yale.
up, I thought that, you know, not what I would call the most scintillating, but certainly one of the more informative discussions, you know, and well worth, you know, listening to again, because I think it points out methodologically it's unstandardized. The cutoffs are all over the place, you know, and this is, I think, makes a big issue as people want to do these panels in-house, is you would then have to standardize and do all the informatics and then validate against what somebody else is using, where there are already multiple cutoffs. So, you know, I'm not sure what it gives you. And, you know, I mean, there's, you know, I've heard that there are, you know, reports coming out that will also say, oh, it really does add to certain things like the history of smoking. And, you know, the problem is smoking is always reported in a, you know, really dichotomous way. They either did or they didn't. Where I think I would really wonder, I'd really challenge people in a research way to sort of get good smoking histories, just to add in like two
which
questions.
none of the studies have done.
When did you stop? When did you start? When did you stop? How much did you smoke at the peak? And and when did, you know, and come up, and probably from that, you could probably come up with a reasonable formula that I bet you would give you 90% of the information
From
of
TMB.
From TMB.
Be interesting exercise. Has anybody done that yet at Memorial? You guys collect pretty exhaustive smoking histories. So.
Yeah, we do, but no one has sort of cross-correlated to that. Yeah.
Why should clinical surrogates
Could I-
trump
could I have
science,
your
right?
database? You know, I'm sure
So let me
people will have a phone
continue
number.
with Ignacio's talk.
It would not be the first time.
Again, the role of liquid biopsy. We're mostly doing circulating free DNA, but again, you can still look at circulating tumor cells. We had a project before the era of the finding circulating DNA, we were looking at CTCs in small cell and astounded by how much we could find, and usually it was a bad sign.
It's
Um,
old technique.
Yeah. So, currently used in metastatic disease to facilitate delivery of targeted treatment, can be easily repeated, obviously, much more readily than biopsies. For the most part, I think many of us are using it at the time of progression to detect genomic changes that correlate with resistance, so T790 and EGFR, although that's falling by the wayside now with OC being used up front. And then if perhaps increasingly over time, ALK mutations in ALK positive. And it's alternative to conventional biopsy in patients with solid tumors where tissue is inaccessible, or you've had repeated attempts and you've gotten unsatisfactory yield, and of course patients who refuse repeated biopsies. So yeah, it's very useful there. So in our initial paper where we looked at a liquid biopsy, more than 50% of our patients fell into one of those three categories. I mean, it wasn't for lack of trying, but it was either inaccessible, we had biopsied 1 or 2 sites and got nothing, or nothing that was really interpretable, and or patients refused biopsy. And I suspect if that's what's happening in academia, it's probably 3/4 or higher in community. Future potential applications. We're working on a project, I'm sure you guys are doing this, looking at liquid TMB. So far, at least in the context of small cell, that hasn't panned out with Atezo. Monitoring response to immunotherapies, although I'd be hesitant to act just on a blood test if the patient's feeling good and radiographically is stable. Early detection of newly diagnosed disease, although one wonders, I think our tests are going to have to get a lot more sensitive before that'll ever be realized. And then perhaps very importantly, early detection of relapse after adjuvant. So again, his slides looking at NGS versus PCR-based methods, the latter for single genes or small panels, the former for larger intermediate panels. And this was an interesting project. I guess Dave Gandara and his colleagues published this in CCR. Were you part of it? Was this done through the Lung Cancer Mutation Consortium, or was Memorial part of this, or no?
I don't,
No.
not that I'm aware
So
of yet.
they looked at folks who had tissue. About 30% had some identifiable biomarker, with EGFR actually heading the list. So out of well over 1,000 patients in this series, 256 had EGFR. You can see KRAS in 61, not quite actionable, but at least defining the disease, and then a smattering of others. And then they went ahead and also sampled the blood. So they looked at circulating tumor DNA and increased the biomarker yield by 65%. Basically went from 30% to nearly 50%. So found additional 42 patients who had EGFR mutation that was not detectable on tissue. Quite a bit more KRAS. Notice the inversion of the numbers there. But also ALK, ROS1, RET, BRAF, MET, HER2, all the others that could at least be acted upon or potentially acted upon in the second or third line. And those numbers are pretty substantial. That's if you subtract the KRAS, it's another 125 patients on whom you could give targeted therapy. And I think this may be one of the most comprehensive series that looks just beyond EGFR and ALK. So again, the major indications, we talked about this, genotyping when biopsy does not yield malignant cells or sufficient malignant cells to interrogate, and then of course mechanism of resistance and other applications in clinical research. Getting to PD-L1, these slides may be somewhat moot. I think everybody uses 22C3 for now, or at least that's the gold standard. Remember that all of these were developed separately, all in the context of very different trials, whether it's first, second, or third line, all with very different cutoffs or thresholds. The Blueprint project, I guess Fred Hirsch's legacy to is like, does everybody know that he's stepped down? Looked at, compared the 4 commercially available, and the one outlier was the Roche Genentech SP142, which tended to stain quite many fewer cells than the other assays, which all sort of grouped together. I think they were fairly consistent, the other three. And this was confirmed both in the original Blueprint project and then a separate NCCN study. And then Blueprint 2 went to another level, looked at real clinical practice and went beyond biopsies. Also looked at cytologies, lymph node biopsies, bronchial biopsies, resections, etc. So 81 separate cases looked at by 18 separate pathologists. And they added another assay. I think the 7310, if I'm not mistaken, is the Pfizer assay. Am I right? Or I'm pretty sure I'm right. So the other three, the Merck, AZ, and I guess BMS assays were all closely consistent. The SP142, the Genentech Roche again, seemed to detect fewer, it was less likely to be positive. The 7310 assay was more likely to be positive. And this was consistent whether you looked at the entire cohort or just the cytology samples. And if you look at reproducibility or agreeability, when it comes to biopsies, it seems to be a lot more consistent than cytology. If you look here on the right, there are some outliers. There's a lot more, at least a bit more variability compared to the biopsy specimen. So this is his last slide. Again, the diagnostic algorithm, tumor, cytology, blood, anything you can get, determine the histology, do PD-L1, although he didn't show that here, but I certainly do it in the 3 panels on the right, squamous adeno and NOS. Limit the number of stains you do to determine the histology. So P40, P63, TTF1, probably no more. I don't know what is done routinely at your institutions, but we still have some pathologists who go to
CK7
town
and CK20.
and get about 26 different IHCs and start depleting the tissue, which is a shame. Again, tissue quantification from molecular testing and then multiplex analysis. So I'm going to pass the baton to you, Marty, and then we're going to have further discussion. Nothing like giving somebody else's talk. And then
Good job.
editorializing while you're giving the talk.
So, okay. Summit Fox Chase, and these are my confession of my sins. So I honestly wasn't really totally sure what to do with this talk
knew
because
you
there's
would
a
do a
very
good job
similar
regardless.
one later on in the agenda, so I sort of made it up as I went along and kind of put in some things that we don't usually talk about very much anymore into this, and hopefully it'll excite some discussion. So first off, we've obviously made enormous progress in advanced disease. The blue sort of Harvard graphic-like slide over there represents the state of the art in 2005. Seems like just yesterday. It was the Chinese menu approach, one from column A and one from column B, and you could get the special of 2 from column B, but we never really recommended it. And now it's already totally obsolete from a year ago. So a lot of progress and a lot of things. So the first thing I was asked about was histology, and back in the good old days, all we cared about was non-small cell versus small cell, and then we started to worry more about histology. And the real thing that led to that were the development of 2 drugs in the early 2000s. Bevacizumab was the first, and pemetrexed the second. So the reason for Bev in non-squamous, to remind everyone, was that it was evaluated only in non-squamous due to toxicity. So in the randomized phase 2, led by Dr. Johnson, then at Vanderbilt, there was a lot of massive pulmonary hemorrhage that was seen. I think there were 6 cases, 4 of them were fatal, and the consequence of that was that when it went to phase 3, the squames were eliminated because they were all in squamous carcinoma. So this was our first targeted therapy, and don't we all remember the excitement with that, because we had finally hit a 1-year overall survival of, I think, was around 50%, and this was a real biggie. The interesting thing is that the attempt to replicate it or have a similar thing, this is with carbotaxol, which was done with Sysgem in Europe, really was kind of underwhelming. But if you played with the numbers and factored out the people who got substandard treatment, never got second-line therapy, it still looked a little positive. But nevertheless, the real role of Bev, I think, remains a little bit questionable these days. So whatever. But the real launch for non-squamous was really this study from Eli Lilly, which was a very, very large study with Dr. Scogliotti in charge of it that looked at Sysgem versus Syspem. And contrary to a recent editorial papers about a year ago or so, which said that the analyses were not planned, et cetera, but they were in fact planned, and this was extremely large, and actually the subsets of non-squamous and squamous were in and of themselves would have been large trials, and it was part of the statistical planning. There was no difference in OS or PFS between the two arms, which when they included both squamous and non-squamous. However, small but real differences emerged in favor of pemetrexed in the non-squamous and reciprocally in advantages of gemcitabine in the squamous carcinoma. And this resulted in pemetrexed being approved in combination with platinum only in non-squamous, and its withdrawal of approval in second line as a single agent when combined, rather as a single agent after a platinum-based therapy in squamous carcinomas. So this was important, I think, for several reasons, because it really did get us to start demanding much larger biopsy specimens, because we really now didn't just need to know, was it non-small cell or small cell, which was the sort of almost TV game show thing of how few cells did you need to have in order to make your decision. We now needed chunks of tissue and sort of set us up for the era that we're in. It's interesting in that pathologist agreement of squamous versus non-squamous is actually rather pathetic. We saw the kappas just a moment ago for PD-L1 where the numbers were up there around 0.8, 0.9, and you have to realize that they're really about 0.5, 0.6 over here, even for, which is moderate, and never much above 0.65, even with experts, and really poor in the community. This was done by Dr. Grilly Olson when she was still a fellow, this study. But it is interesting that this study was done only based upon morphology. It was not based upon knowing P40 or 60 status, TTF1, et cetera. So it's really before the use of, or without the use of a lot of IHCs. So we really still have no idea whether or not that adds or doesn't add, what it does for the smaller specimens, et cetera. So is histology still relevant? Well, very clearly it is, because we have now the two approved regimens in non-squamous, the carbo-pem-pem and the carbo-tax-bev-atezo, which I'd wonder how many people will actually ever use this, but certainly carbo-pem-pem has now entered fairly widespread use. Dr. Langer being the prophet of that, though it's interesting, as I looked at that study, it is fascinating because it shows the difference between even a large randomized phase 2 and a phase 3, and that the control arm does twice as well in the randomized phase 2 as it does in the randomized phase 3. So it's really very, very fascinating as you go to these, and it's a warning, people should look at those things because it is a cautionary tale of taking too much information. Nevertheless, got replicated, a rare moment, and that established that. And then in squamous, we now have, I think, where again, this carbo-taxol bev-atezo sort of stood alone for a while, just as a few weeks ago, the carbo-taxol, or if you really like spending money for no reason and supporting, I guess, the LA Times, you buy a nab-paclitaxel and pembrolizumab, and stuff. I have no idea why anybody would use nab-paclitaxel, but this study really works. Was shown to be very effective in squamous carcinoma. So we have 3-drug chemoimmunotherapy regimens for both of the histologies. So histology remains quite relevant. So actionable mutations. I'm kind of sorry my colleague, Dr. Bourget, is not here. We somewhat disagree on this definition. And this is what drives our clinical testing, as was just shown. We want to find something we can do something with. It's got to be more than just of academic interest. And the definition really varies. Dr. Chris, tends to use it as anything that we've kind of got a study for, and we've thought about, and maybe it's something that we can, do something with now or in the future. And somewhere somebody believes that they've got a drug, and Haas also, I think, states that to me, an actionable mutation is something for which I have an FDA-approved drug, or hopefully at least an NCCN guideline with a listed agent that I can write a prescription, and more or less insurance will actually cover the cost. Because other than that, it's not really actionable because I can't act on it. Only in that situation is it truly there. So, this is one of the many pie charts. What's interesting is as you look at these various pie charts, the slivers are somewhat similar, but as you get down into the smaller ones, and what I like about this one in particular is I think it's, and this comes from, I think, the TCGA, ALK fusion over here is 1.3%, and for, something I've been kind of arguing about that for a long time, we see up to 5 or 6% in some, and I think it's probably more real world, a lower incidence, as we get more and more people, not just from referral centers, or not just the people that we want to run these panels in because we're looking and we feel, gee, they were never a smoker, let's find it, but a less enriched, more real world populations. So let me talk about the gene nobody likes, because we can't do anything with it, and that's RAS. So I wrote this all out. I took this from one of the papers so I could remember something about it, and it said, RAS is bound in a GTP, and it's in GDP in its inactive form, and then when it gets stimulation, then it gets into the GTP form, and that's activated, and if it's mutated, then it stays in the active conformation and ends up stimulating all of these things and does many, many bad things, cell growth, proliferation, invasion, migration, et cetera. So we all know that we have not yet been able to target KRAS, but we get this back, and should we, and what does it mean? So first off, not all KRAS mutations are created equal. There are some that are very common, and they differ between smokers and never smokers, and I think that's an important thing to kind of look at, as we go by on this, and there may be ultimately, who knows, or differences may or may not arise, from these mutations. There, as I'll show, perhaps some difference in which codon things are in. So as a prognostic marker, so 1,000 ships have been launched discussing KRAS. Very few of them have really shown advantage. I always thought of KRAS as having a worse prognosis, but actually when you look at the totality of the data, we have no effing clue, because it's all over the place, and these overall survival hazard ratios are, everything from nothing to, 1 essentially to, 1.3, maybe as high as 1.7. So we really don't, if nothing else, KRAS probably in the population is not as horrendous a prognostic marker as many of us thought. Is it a predictive marker in adjuvant chemotherapy? This is a paper that came from the LACE meta-analysis group. This took, there were over 1,500 cases. I think the overall number of the patients entered in this was from the ANITA trial, one of the other European studies, the CLGB study, whatever, was about 3,000. They had about 1,500 that were evaluated for RAS, and they ended up with 275 with codon 12, 24 with codon 13, and 1 in codon 14. And if you go through this paper, it's a JCO paper, curve after curve. There's about 4 or 5 panels like this, and they're all very overlapping. The only exception is looking at codons 12 versus 13. 13 seems to be bad for you, but the numbers are very small, and I would certainly not write home to mother about that. Given the number of tests that were done, it's probably within random chance, and it's just way too small. So the answer is nope. To that as a predictive marker. So not a predictive marker for chemotherapy therapeutically. It is a negative predictive marker for benefit from EGFR TKIs. This is data we don't really need anymore, but it comes from before the mutations were clearly described. And it's not 100% mutually exclusive from the other activating EGFR, ALK, et cetera, mutations, but very close to it. So I always felt part of the value of KRAS was, if you have those in-house panels of 6 or 7 genes and KRAS comes back mutated and it's somebody with who may fit the demographic, they were a smoker for 10 years and they quit 40 years ago, if they're KRAS mutated, I don't feel deeply compelled to, find other things now. Maybe that will change, but I still think it tends to be pretty mutually exclusive. And I think that's an area for discussion. Is there emerging literature on this? You see these scattered case reports. So KRAS may or may not predict for immunotherapy responsiveness. The example I give here is actually negative, where mutant versus wild type are compared. This is the IMpower 150 trial. Mark Szynski published. This comes from the supplemental data. Absolutely no difference. So we just don't know. Again, I had a feeling because one of the first patients I treated with immunotherapy was actually a never smoker with a KRAS mutation. And it was really quite fascinating in that this was a gentleman who came in, looked quite ill, and it was a real question whether or not even to treat him. He was requiring 4 or 5 liters of oxygen, barely hitting 88%. And fascinatingly, after some nivolumab, a few weeks later, his CT didn't change very much, but his O2 sat went to about 100%, and that was a sustained clinical benefit for close to a year. So, I always had in mind that maybe this was good, but it's not clear either. So what about other single gene abnormalities in immunotherapy? And this has been alluded to already about STK11, that in this case it did not have the deletion there, beta-2 microglobulin, JAK2 because of its role with interferon gamma. Is this predictor resistance to checkpoint inhibitors in the paper? And this is with the memorial data there from HRISV. There was actually no real not a lot of value to that. That STK11 did seem to be, did not tend to get as much clinical benefit. B2M, JAK2 were negative for that. The MDM2, and that should be 3, I think, amplifications, or 4, have been associated by others with hyperprogression in some reports that was not found in this paper from Memorial. So I think, again, if we're going to discuss stuff, I'd be interested in hearing what people know about this because it's sort of emerging. So let's get into the specifics of things. And actually, it may turn out that it's good that I had these slides in here, and I'd take maybe a little bit longer time, or maybe the same amount, because I'll get in the data on everything else. So BRAF, we see a few % of the time, and dabrafenib, originally approved for V600E, BRAF mutations in melanoma, along with trametinib. It definitely works in non-small cell lung cancer, and you get this beautiful waterfall plot, the kinds of things that we always used to dream about and never saw. And some of these patients get rather durable benefit and has an FDA approval in this situation, fully published in Lancet Oncology, and clearly very beneficial. The problem is we see over and over again BRAF mutations that are not V600E. And so I've looked up some of this stuff, and I think if you're nearby, like, you're a codon away and say 599, I think it still can work. However, when you get to a lot of the others, the answer is no, it doesn't, and it's pretty useless and give them chemotherapy. And it's sort of, I don't know, I find it very devastating when you have the patient who's a never smoker and one of those non-V600E or equivalent mutations shows up, and it always seems to be a young, totally wonderful individual who never touched a cigarette, and and they just don't do very well. So chemotherapy. So what about HER2? So again, I'm continuing my theft of Memorial data here. This is a slide that I swiped from a Mark Chris presentation. De novo HER2 amplification is certainly seen in lung and many other cancers. There is approval of Herceptin not only in breast cancer but also in esophageal, I think gastric, for HER2 amplification. But the level of amplification is generally not very high in lung cancer, but it certainly is seen. It can also play a role in acquired resistance to TKIs, both with amplification and both within the first and second generation, as well as with osimertinib as well, and that it can be another mechanism for resistance. So HER2 amplification has emerged as a mechanism of resistance to all 3 generations of EGFR TKIs. But which drug should we choose? We got a lot of choices. You know, I've tried using afatinib, that was pretty useless. Decamitinib is now legal, so I guess we could try that. But there's plenty of other drugs out there, both small molecules, big molecules, conjugates, et cetera. And there's some data to support, you know, a little bit of them. Decamitinib, certainly this paper that was in Annals of Oncology, showing at least, you know, some degree of response over there and benefit. But, you know, it's really varies, depends on the exact insert, the mutation, as to whether or not anything will work. So, you know, I think that this is, you know, it adds to the complexity. The more information that we get back, the more complicated and difficult it becomes to make decisions. Again, somewhat analogous to the BRAF situation. You get things back that are not classical, and they're sometimes very infrequent. And you've got a report of 2 cases or 3 cases and very little information on what other modulating factors there are. Ooh, what was that? I don't know. Sounded like a shot. So, so this is with a drug I've always liked, trastuzumab emtansine, the antibody drug conjugate. And it definitely shows degrees of response and benefit to the drug. Here's DM1, the other TDM1, and HER2 mutated. Again, nice waterfall plot with some real responses. But it is interesting in that they're not very durable. You know, and that's, I think, one of the things about HER2 disease. Even the reports of benefit in this, it's not like the 80, 90% that we see with the TKIs and, you know, the other activating mutations. It's just not the same. I mean,
But
clearly
beats
there's
chemotherapy, though.
What?
Does beat chemotherapy response
Well,
rates.
actually, it doesn't.
No,
You know, and that's an
44%.
interesting aspect to this. So first line without HER2/neu targeting therapy, if you actually look at it, response rates are virtually the same. Overall survivals are no different. So whether you have to go, there was actually a debate on this at the Santa Monica meeting last year, which is where I snitched this slide from, and it's actually not so clear. You know, again, there's always going to be the anecdote. I mean, but, you know, I don't think you've deprived anybody of something if they get chemotherapy first and then go to the, you know, the HER2 antagonist.
I think
of your
actually the
choice,
first
you
2 lines are without HER2 targeting treatment.
Right, that's what
so
I'm
they
saying.
did better.
That's what I'm saying. It's
Oh, I
chemotherapy,
see.
first line without, and you actually have overall survivals. That's what second line without, and then these are the various EGFR, trastuzumab, and then the various other, you know, TKIs. And it's not dramatic, you know. And again, I think that's probably going to vary almost mutation by mutation situation, amplifications versus mutations, different types of mutations. So,
But don't you think that
much more
HER2 mutated population is the wrong population for TDM1 anyway? Because it's an antibody drug conjugate
Yeah.
where the smart bomb is
Should be
made by HER2 targeting on the surface where it should be overexpression,
But I
not
think,
mutation.
Yeah, but as I recall from the paper that was just published, actually, again, from the Memorial Group, that was meaningless. That actually was the
Yeah,
mutations
that's
that were
right.
more important.
And you know why that's the case, we don't know, but H-score for HER2 is not predictive,
Yeah.
either in the literature or in the
So that was it JTO, I think it was?
JCO.
JCO,
Yeah.
yeah.
makes-
So this is within the last 6 months,
But
year.
makes no biological sense if you
It
think
makes
about
no sense whatsoever.
Yeah, exactly.
I agree. And, you know, because I actually brought this up as a proposal with LungMap, and so I spent a little time thinking about it because, and you know, some people had said, well, it should have this, exactly the point that you made. And I said, well, yeah, that makes total sense to me. And then that paper came out, that threw a wrench in that bit of logic. So, you know, I think as our colleague Dr. Khoury puts it, nothing wrecks a good hypothesis more than data. Okay, so let's move along here. Oops, sorry. So there was, not sure what I did with that slide over there. So here's just, you know, MET-amplified crizotinib, clearly very efficacious there, hitting about 70%, and now, you know, clearly very good, though the response rate's still, you know, not as high as we would like, but this is the exon 14 altered, the skipping mutations. I love skipping mutations. Brings me back. You know, now approved, I think, is this got an FDA approval in
Not
MET
yet.
exon 14? Not yet?
Yeah,
Definitely got an
breakthrough
NCCN.
designation, but-
Yeah.
Okay, breakthrough designation. I knew it was close. So, and then the RET inhibitors, you know, also, you know, something you see pretty rarely, and again, not as dramatic frequently as we would like, but nevertheless, I think, you know, coming up there. And certainly lots and lots of drugs for relatively few
So there are some
patients.
new ones that are
Yeah.
quite active, and I think
Right.
all
Was
of
it the
these are,
Loxo,
this is
what
sort
you
of the
three- yeah.
2017
Yeah.
story, and the 2018
Yeah,
story.
I may have another slide.
do you have,
because-
yeah, there you go.
Yeah, that's
Oh, no,
track.
that's on track. So-
Yeah, but the Loxo, yeah.
Blue,
the
6, 6, 7,
Loxo,
there's
yeah,
at least 2 or 3 drugs now that
Yeah.
have much higher response rates, much more durable PFS. And I think arguably, and we can talk about this a little bit more later, maybe tomorrow, potentially move into first line as opposed to second line. I don't think any of us would have given these drugs except second or third line. So, yeah.
Yeah, and I think the importance with all of these drugs is, I think, if we're not going to use them in frontline, and the reality is we've never actually proven that EGFR TKIs really have to be in frontline. If we could have a great argument about that, because overall survival has never been shown to be advantageous in any randomized study. And I've always wondered about a planned sequential approach where you'd give them a couple of courses of chemotherapy, or the very interesting chemo TKI study that just came out from it was a Japanese group, and which I think is actually quite important and challenges the revealed wisdom, because we were very quick to run to this, and I think probably a mistake, and we should
I
probably
thought
go
the
back and look at
combined
stuff.
analysis of Lux
Yeah.
Lung 3 and 6 did have
That's
a 12
combined, combined
Yeah.
and only an exon 19.
Exon 19 deletion subset was 1 year difference though, quite impressive.
Yeah, but the problem with unplanned combinations, 2 separate drugs, and and remember, they came out and there was no difference in those studies. So the reciprocal of that was the exon 21s did worse.
Yeah.
So that's always one of those problems. If you get things that are tied and suddenly somebody's doing better than somebody had to have done worse.
But in the osimertinib era, you shouldn't have
Yeah.
that question.
And in the
right?
OC era,
Yeah.
who knows? But again, I don't think it eliminates the question of whether we could not necessarily do them at progression, but do them in a planned sequence with with a limited course of chemotherapy followed by those agents versus to really look at this and see if it makes a difference. I mean, we've never really tested that hypothesis.
I think at Sloan Kettering they combined them, chemo and
Yeah.
EGFR inhibitors.
Yeah, that's in the second line setting, but I
Yeah.
think you're not, that perspective I think is not incorrect, because the question is, exactly what the clonal heterogeneity for resistance mechanisms looks, before, after chemo, and certainly taking a look at the efficacy of first line chemo alone, which no one's going to ever do now, in EGFR mutant lung cancer, what does that look like versus first line chemo after osimertinib?
That ship has sailed.
Right,
I
that
don't
ship
think
sailed.
you
But one could
It's
easily
not
see,
irrelevant
I mean, would it
question.
be, again, I doubt a lot, but, would I have serious objections to, and, let's face it, to an extent, we're doing this. Because if a patient comes in now that, let's say you have a never smoker, and they have 0 PD-L1, okay? That's what comes back quickly. They have advanced disease. They need to be treated. You give them carboplatin pemetrexed while you're waiting for some of the other stuff to come back. If you felt pushed to the wall, and then your EGFR mutation comes back, you could switch immediately, or sometimes, it's all over the place. Let's give them 2 to 4 courses, and then we'll give them the TKI. So to an effect, we have done this, without waiting while people are responding. And I'm not sure that the ship has completely sailed. Again, I wouldn't do it at progression, but could we not do it in sequence? Again,
We're gonna
not
hit-
likely to happen, but an interesting
We're going to
question.
hit this
Yeah.
topic when Greg
Right.
comes in and talks
Yeah.
about EGFR.
Okay, so TREC, obviously, this is another all the rage, for the one patient you may ever see in your lifetime, if you're not in some quaternary care center. I mean, and I think it will be remarkable how many drugs we have for like hematology here. We have many, many drugs for diseases that never come in the door. So that's TREC. So here are the validated and not so validated. I'm not supposed to mention EGFR and ALK, but obviously the very validated one. And then ROS1 BRAF, we have the FDA approved, and then sort of our emerging areas, HER2, RET, MET, and TREC. And the ever important NCCN guideline that lets us write for these things, because it's really important that the $3,000 a month or so that these things cost, somebody's got to pay for it.
$3,000,
At least.
a lot more.
Well, for the orals, it's generally 3,000 or 4,000. So whatever, that's what I have to say. Thank
Very
you.
good. So we've got, considering there's only about 10 of you back there, I must have gotten 20 questions. So They're coming in hot and heavy, and they're all quite good. So we have some scheduled things to talk about, but I think some of these we've already addressed, and some of these are actually been brought up by the questions. So I'm going to open this up to the group. I'm going to go in the order in which they came in. After you order molecular testing for a patient, a number of questions. Who is the first recipient of the order? Does it go to the pathologist directly? Is it some sort of intermediary? Who's responsible for locating the tissue? So a lot of logistical issues. How often is there a problem finding the tissue, particularly if it's done outside? And how much time does it actually take to locate the tissue for testing? So MJ?
So I'm sure it's different places. What I've learned over time, the best thing to do is to order it, send the order to Foundation. They then contact the pathology department of whichever hospital the tissue is at, because we get patients from all over, not just our own institution. And they get the tissue from there, and then they keep us abreast
So
of where the
Foundation
tissue
does
is.
the work.
They
Once you
do
put
all
in
the
the
work,
order.
and that's probably the best. And I've found some hospitals that have been educated, they do a lot better job at picking the exact number of slides and sending it properly, others not so much.
Nasser?
So Corey, I think that, you know, the answer is that it varies, and you ask the pathologist directly, and sometimes it's easy to find, and sometimes it's hard to find, and sometimes it's all used up because of IHC, and sometimes, you know, they can't cut you a piece to test, and, you know, it's all over the map. But this is why liquid biopsies are so beneficial, is that you can just draw the blood in the clinic, and you generally can get a result back in about 5 to 7 working days. And we should soon have TMB on that. The only thing that you don't get on that really is PD-L1 expression.
So you're,
And if I'm having trouble, I just draw a sample in the clinic. And to be frank with you, I usually get the liquid result back way fast while we're still trying to find tissue.
trying to track down the tissue if
Back
it's done
in
outside.
some small, I just can't find it.
Paul, do you have designated people that actually do this, or are you
We do. I
Scott
think
puppies
once-
who retrieve the tissue?
There are. They are little cats that go back in the back. No, but there are sort of these accession specialists who help, I think, to shepherd things along and then email us if there's some kind of specific issue. So things happen fairly in a sort of routine fashion where we don't have to get involved very much. And one thing that helps, I think, is that it doesn't happen in everything, but more often than not, at the time of the diagnosis, more unstained slides will be cut when they're trying to, you know, make the diagnosis, just to have on file for next-gen sequencing, understanding that more often than not we're going to order that. So that saves some time, and the unstained slides are ready for, you know, for DNA extraction. So.
Marty?
So, you know, it's just highly variable. I think at Fox Chase, it's actually pretty easy for us to get the tissue sent for analysis. It's very responsive. At my prior institution, it was nightmarish. It was actually faster.
Which one of your prior institutions?
The most immediate prior institution. Well, the other one was sort of before we had this as a major issue. But it would take like forever within the house to get something, say, sent out, because they didn't have any much in the way of in-house testing. So it was faster but to get that chunk of tissue drawn out, you know, at a large university setting was very painful. While, you know, if we filled out the Foundation report, you know, they would sort of swoop in at the community and get the stuff, and it became really quite a joy. We actually were happier when the people got biopsied sometimes outside, you know, because it just got done very, very efficiently. I always found their customer service to be quite excellent.
Nasser?
I wrote a note while you were giving your talk, and something that Marty had talked about as well. So Marty had mentioned that, you know, these driver mutations are not completely mutually exclusive, but they are generally mutually exclusive. And the issue is, you know, do you do tissue testing? Do you do a liquid biopsy? And you pointed out the Gandera paper, and there's actually another paper which shows that you can find a lot of mutations in liquid that you did not originally find in tissue. But, you know, if you find something in tissue, I don't know that you need to do the liquid to find something else. So,
Oh, sure. I
yeah.
think that was the point. There was
Yeah.
a value added. They went from 30%
Yeah.
actionable or at least definable to nearly 50%.
If you find a KRAS mutation in the tissue, I don't know that we should be looking in
I
the
probably would
liquid.
still do it, but I share your skepticism that you'll find anything else. On the other hand, nearly 2/3 additional actionable markers were found in blood that weren't seen in the tissue. So it's worth it. And we actually then looked at, in our group, we looked at what happened to those patients. This wasn't just EGFR, it was across, and the response rates were very similar to the literature. I mean, these were real findings. These were
Yeah.
actionable findings.
And you know, you're right, the response rates are reported to be just as good when you find it in the liquid. But, you know, you get the allele frequency, and I always feel a little uncomfortable when you get, you know, you find one of these mutations in the liquid, and the allele frequency is like 0.01%. And you wonder how meaningful the target really is. But we still
I've
treat.
still acted on it. I feel
Yeah, I
it's
still
like
do
being
too.
a little bit pregnant. Ultimately, you become a lot pregnant. But you're right. I have the same qualms. I wonder if it's really, you know, if anything's going to happen or they're going to really derive a benefit. Our biggest issue is when somebody has been biopsied outside, and the tissue, retrieving that tissue, it can sometimes be a nightmare. The outside pathologists hold on to that tissue, or they've already sent it, or you think they've sent it, and you have no way of really knowing. So the chain of custody, I think, is a big issue, and I agree with you. Foundation, that's part of their value added. They just take over the process. I mean, they want to get it done. They want us to, you know, keep going back to them, and goodness knows it's something that you don't want to do, and we certainly don't have the time to do, and it's a real scuddy type of process that, but a necessary evil. So we're getting some additional, again, excellent questions. What type of patients do you order PD-L1 and NGS? I think we discussed that before. Pretty much all adenos, regardless of smoking, and all never smokers or posse smoke, you know, remote former.
Well,
Nasser,
all patients
do
with
you do it on
non-small.
everybody now?
With PD-L1, you should.
PD-L1,
Yeah,
yes, but what about
that's
NGS?
mandatory. Well, I generally just do it on the non-squames.
Non-squames. MJ, same.
Yeah.
And Marty?
So, you know, the non-squames, I think, definitely need mutational testing, and then for squames, if they have some demographic that particularly lends itself, you know, again, the
East
occasional
Asian never
squame and a
smoker
never
with squames,
smoker,
right?
you know, I mean, then you just got to do it, you know, and stuff, and so occasionally it'll come up.
Paul, I
So
think you answered this before, but is pretty much everybody getting NGS?
Including squames, yeah.
Including squames. So our out for the squames is the MAP study, the lung map.
Yeah.
So we're pretty much using that as our approach to get those folks tested. But off study, I tend not to do it. You know, somebody comes in from West Philly, they have a 100-pack-year smoking history, they have squamous, they're male.
They're immunotherapy patients.
The likelihood is very low, although I've been chastised for doing that. What happens when you get it PD-L1 first before the NGS? How many wait and how many act on it?
Well, depends on how strongly positive it is and what the clinical situation of the patient is. I've been burnt, you know, I had a patient who I thought she had brain mets, she had large tumor burden, she got brain radiation, whole brain, because it was too numerous to count. And we started chemoimmunotherapy, and she came back with ALK. And I thought, okay, there's nothing wrong with giving one more cycle. Once I start chemo, I do
The
two
key thing
cycles
is
and
you
a
gave
scan.
chemo and immuno, not immuno alone.
Yeah, well, with current data, I think that's appropriate to do. And this was a very recent patient. And for some reason, she got hospitalized and went straight to hospice, had no family. I could not retrieve her out of hospice to give her an ALK inhibitor,
Really?
and she died. I really feel bad about
Even
that.
though she had ALK, you couldn't
Yeah.
get her. Wow.
Yeah. So I learned my lesson that in future, if it's ALK, I will start an ALK inhibitor even if she's on day 8 of her cycle, for it to
For
be
fear that
instituted.
you'll never get her to
Yeah.
the treatment. That's very interesting. Nasser?
Yeah, the one concern, and I agree, that's what I would do too, is there is some data that you can increase risk of pneumonitis if you overlap some of these TKIs and the checkpoint inhibitors
If
too
you
close.
overlap, but what if you, the concern still exists if a week, 2 weeks, 3 weeks of it, the checkpoint inhibitors are not actually gone.
Yeah, no, this is true. So there is a little cautionary note with that. ALK, you can do IHC, and we're doing IHC in-house, so, and that's a very good, I think, marker for ALK fusions. But I think it's exactly what Mohammed said. You know, it just depends upon what you think the likelihood is that you're going to find something. If somebody has a PD-L1 of 90% and they're a heavy smoker, and they're not looking well, you may just go ahead and start them on treatment because they're
When
very.
you say start them on treatment, what treatment do you start them on? Some combo?
Well,
Some
you know,
chemo
if their
combo.
performance status is sufficient to give chemoimmunotherapy, I still tend to do that. If they don't want chemo or the performance status isn't so great, I'll just do the Pembro.
Paul?
Yeah, same thing. I mean, if there's a high likelihood, never smoker of having EGFR ALK, I'll.
You'll do spot testing on that person. You won't wait for the
Spot testing will have
NGS.
it, and at a minimum, I'll, try to push to wait for like the liquid biopsy results, which we, sort of routinely do in parallel. But I think apart from that, you will run with the PD-L1 result and treat accordingly.
Marty?
So, I think pretty much very similar. I think if a patient demographically is likely to have a driver mutation, and let's face it, the two real biggies are, EGFR and ALK, then the PD-L1 doesn't really, that's sort of almost like a false positive. Those patients don't do well with immunotherapy. So really, that's where I'd probably wait on starting that. And I think if I were, push came to shove and I need to start somebody on something quickly and, it's going to be some delay getting back, an EGFR, ALK, the basic part of the panel, I think that chemotherapy actually is totally reasonable, with, say, carboplatin and Alimta, and wait around. We know that never smokers don't do well with immunotherapy. Yes, there is something when you do chemoimmunotherapy in this group. I don't have any problems with that, but you can certainly do that, but you have to make sure that you're getting it. One of the things I've also seen coming from many of the community sites is that it'll get noted that they had testing, but sometimes it was like, well, we didn't have enough tissue to do the EGFR, the ALK comes back. It's like you said, the strange things sometimes come back first, and they didn't have enough to do the demographically more likely things. I mean, EGFR is a lot more likely than ALK, which in turn is a hell of a lot more likely than ROS, TRK, and RET. And yet, strangely, ROS tends to come back first and stuff. And so, so I think that, yeah, if you've got a high PD-L1 and it's a good possibility that the patient is going to have a mutation, you can just start them on chemoimmunotherapy and then wait.
There was something in your pie here, not this one. There was another
first one?
version of the pie.
The first, early on.
That looked a little odd. No, I think this was here, where exon 14 was 4 times more common than ALK fusion. So I'm not sure who baked this pie, but this is
Well,
this does not
this one
cohere with
actually
my,
comes out of the
my
TCGA, and
practice.
I think that I cut it out of a slide from one of your colleagues from a few weeks
Okay.
ago. Your pathologist.
I mean, I certainly don't see that frequency of exon 14, and I'd have to say we do see about 2 to 5% ALK. It's not 1%.
Well, referral
Yeah.
centers.
But what's the N here? We don't know.
Yeah.
It's a TCGA thing. I have to pull the original paper. I mean, but again,
No,
it's
TCGA was 1,000
yeah.
tumors.
But there were also more people
For
that had
surgical,
surgical
too.
specimens. So,
Yeah.
I think the problem with all those pie charts when it comes to frequencies are we do not have a population-based analysis in any of this stuff.
It's all
because
referrals,
It's mostly referral, and there's still going to be a much greater tendency to do the more comprehensive analysis in the people who are demographically most likely to have mutations.
Yeah.
They're also the people most likely to get to places where they're going to do this automatically. You speak to people in practice or at universities in the Midwest, in a lot of areas. I mean, I know at University of Maryland, we were looking quite actively since at least 2006. We rarely saw ALK mutations. If we had 10 or 15 in a 10-year period, I'd be surprised.
So we're going to go around the room the other direction, start with you, Marty. What is your preferred liquid biopsy assay? Do you do FMI liquid? Do you do Guardant? Do you do some other company? Or doesn't it matter?
I've sent them in both to Foundation and Guardant. I think we've, I don't have any strong preferences yet. I haven't done a vast number of these at this point.
Paul?
It's whatever we're doing routinely research-wise. So right now it's with Resolution Bio.
Resolution Bio?
Resolution Bio. That may shift to Guardant, but yeah.
Nasser?
Yeah, I'm not a commercial for Guardant, but Guardant does have the most published data for liquid by far, and I think they have the best turnaround time, and so I exclusively use them.
I vacillated between Foundation and Guardant by, the level of disappointment that rises to a level that I switched to the other and then back. But currently it's Guardant.
So you're using Guardant
Yeah.
typically. So when you order that, I mean, you have somebody do the kit in the office, or how's it done logistically?
They send somebody to patient's house.
Really? Okay.
Yeah.
We tend to do it right in the office. We literally have a whole bunch of shelves in our touchdown space that have the Guardant assay, and while
Our
we have them in
staff
the
didn't want to
clinic-
deal with it, so our staff did not want to deal with that additional work.
No, I agree with you.
Yeah.
It's more scut. We're doing Guardant primarily because we do have a relationship with them from the standpoint of a bunch of trials. I don't think we necessarily have any preference, but they have a track record. We're comfortable with them. The turnaround's quick. Their website is usually accessible, so you can get the data in pretty quickly, and then you can transfer that to the patients. And now it's sort of downloadable to Epic, so it's been I've been fairly pleased with them. Keeping up, Marty. T790, highly relevant when OC was second line. A lot less relevant potentially now, but what are your thoughts? Maybe it was I or someone else that said that we're not looking for that as often because we're using OC frontline.
It's the shooting, it's one of those things whose time came and has passed.
Very
in some
quickly,
ways.
but-
Obviously
so-
it still shows up.
Well,
but
frankly, in
most of us are using
the
OC
people who are
frontline, yeah.
progressing on OC, it doesn't show up that
Right,
often.
right.
That's the issue. So, but the
But-
concept doesn't go away.
You'll see some de novo T790Ms.
Pretty
still,
rare.
But it's not. The world has marched on from that.
So
Some-
we're testing
some
them for it,
people-
but we're not finding it in the OC failure, those who progress on OC.
I mean,
Nasser?
I haven't really done this, but some people have utilized it in that if you're on OC, you progress and you still harbor the T790 as a reason to continue OC and add something to it. That's what others have done. I've heard others
You mean
speak.
after second line OC?
Yeah.
Because usually, again, in those who get OC primarily, you tend not to see much T790. MJ, your experience? Same
Well,
thing?
my experience has been different because my first line TKI was afatinib for the last several years, ever since it came, because I always gave it in 30 milligrams and didn't see the toxicities that drove people away from it. And when I tested with Guardant or Trovagene, in about 25 plus patients, I found one person with T790M, which was in sharp contrast to the literature. I still don't understand why that was, and that's what lost my faith in Guardant initially. Like, where are T790Ms? And then, now that world has changed, there's no reason, from my standpoint, to think too much about it in first line. I mean, currently I have about 15 patients, I think, on osimertinib, and no one has progressed yet.
Really?
Yeah.
Eventually they will. It's still
Yeah,
a
I know.
TKI.
I'm talking
We've-
about first line only.
We've seen our first T797, although I don't think it was in the right position. I can't remember cis or trans. We've seen some MET amplification. I haven't, but some of my colleagues. We've seen a couple of transformations to small cell, which is in the literature, and it's always disturbing, and they don't do well. But I've not seen anybody who started on OC develop T790 as suddenly pop up. And I guess what would you do if a situation that would be tempted to increase the dose maybe, or add something? I don't know. PD-L1 in liquid. I don't think that's still experimental. I mean, there's blood-borne mutation testing, but it's at least as it'll be discussed by I think Nasser, hasn't panned out for different identifying folks who are going to preferentially benefit from Atezo. At your institution, do your pathologists do PD-L1 IHC for all tumors or just lung patients? I guess that's getting beyond
Just-
our level of
just lung.
expertise.
We only talk to
I
lung
think it's only
pathologists.
useful in lung. Well, although head and
But in
neck,
a
it may have a
bladder,
role.
it's required.
Yeah.
But it's a different, so I actually just had this discussion today with one of my GU oncologists, is it is actually required because there's a black box about using these agents in PD-L1 negative. But it's a completely different PD-L1 scoring system. It's like another language.
This is for bladder or
For
for the-
bladder, for
okay.
bladder. And you cannot use, because it's a black box warning that, you know, these drugs kill people in those who do not express PD-L1.
Is this a question for you, Marty? Again, going to KRAS, because I think your mention of KRAS triggered this. Potential of TIL therapy or cancer vaccines for KRAS, or you think we're in a therapeutic desert?
Right now, we're still wandering in the desert,
Desert.
and there's really, you know, many mirages and not even a good
Mirages.
not even a good oasis.
No oasis.
You know, I mean, you know, the thing is that at a certain point, you know, somebody will figure a way. There are some drugs that, at least in the laboratory, do look like they can, you know, target KRAS, not by hitting the site, but, you know, sort of in a Rube Goldberg contraption way of attaching elsewhere on the molecule and altering the conformation that way.
Paul, somebody doing KRAS at your
Yes, we
place?
have
Is
a-
it you or someone else? I'm sure with everybody so super specialized, there's got to be a
Yeah.
KRAS
We have
guru.
our KRAS specialist.
So Casey Arbor, who's a new attending now, has sort of taken off a trial that Greg Riley had, taking a look at FGFR in combination with MEK inhibition. And so there's a phase 1 trial of ponatinib plus trametinib that's ongoing. The first patient's on, doesn't have a response again yet. So that's one way, based on some good data from the Scott Lowe lab, that this should theoretically work. I've got some data about KRAS mutations in the context of KEAP1 loss.
Turn it
that we're
off. I
working
thought
on
it was
also.
off. Keep going.
So I think people are we're like, I think, in sort of a version 2.0 era of trying to target this in a different fashion based on some additional molecular data and biologic data that's emerging. I think the covalent inhibitors look interesting also if that can get into the clinic.
So, I mean, the issue is we identify these folks.
Yeah.
They're abundant. It's the most
Yeah.
common mutation. And then, you know, they get chemo plus pembro.
Yeah,
Do you have any KRAS-specific trials in HOG?
We have a basket trial. It's a phase 1 with a KRAS inhibitor, but it's specifically for G12C mutations. And I don't know the name of the drug. It's in our phase 1 group, but it's a basket trial, so any tumor type, primarily colon and lung.
Anything going on in Florida?
Yeah, we have a trial in the pipeline. It hasn't been through the IRB yet, and it's a TKI, but I don't remember the name.
We actually, KRAS and mesothelin seem to be fellow travelers. So believe it or not, we're using KRAS to identify folks that we're screening for mesothelin. God help us, we are doing CAR T and mesothelin. I'm not a big proponent of that. It is nowhere near ready for prime time. It is incredibly toxic. It's rather, it may be premature. Maybe. It probably is premature to even explore that in solid tumor. But they come to us asking for CAR Ts, so we've got to have trials at least looking at it. I think we answered the PD-L1. Again, follow up to the RET, Marty. Do you think LOXO-292, and this will be covered by Tony when she comes in tomorrow. She was due to speak today, but again, her flights were canceled, so she'll talk about further. But LOXO-292 and BLU-667, are they similar, different? Paul, any thoughts?
I mean, they look.
'Cause I know
they
you're
both
the-
look great.
Huh?
right? I mean,
They
both-
certainly look a lot
they
better
look a
than
lot-
what we've
yeah,
had,
so
right?
They both look great. So I think these very specific RET inhibitors. I mean, it's track inhibitors. I think they're. I mean, it's great seeing these data come out, and you know, we'll need to solidify that. But I agree with you. This now enters the sphere of can we consider this in the first line?
Yeah, and regarding the track that you mentioned, you know, will we ever see one? It's 1 in 1,000.
Yeah.
So you have to see 1,000 lung cancer
think it was-
patients and
what is
sequence
it,
1,000 to see
one
one.
Trek patient in Japan or something like
So
that.
I may have seen my one and only because I had one who had it.
You've exceeded your lifetime.
But he didn't
allowance.
qualify for the clinical trial because of his underlying immune. He had interstitial lung disease. His PS was a bit rickety. he never got the inhibitor, which is a shame because I think there's still a Lazarus phenomenon that can happen with these drugs. There's a lot of questions here that are specific for EGFR. I'm going to save these for when Greg comes in a little bit later, but including exon 20 and then this whole issue of chemo plus TKIs up front. And then someone wants to know about our Pembro JAK2 inhibitor study. Very early, we've got all of 3 patients on it. Only started 2 months ago. It's in 50% or higher, so it's a frontline regimen taking standard Pembro plus the JAK2, and it's the part of the Sean Parker project that we're doing. But there's not much else I can really say about it except that any comments on it are premature. In reality, what is the maximum time you've waited for molecular testing results? 6 weeks, 4 weeks, 3 weeks? Does this vary by line? Is there a cutoff for no longer willing to wait? And again, this gets to the practical issues. MJ?
Well, I think that they say 3 weeks, but in practice, it's more like 4 weeks
Yeah,
by the time you order it.
supposedly it's between 2 and 3 weeks from the time they get the tissue.
Yeah.
So if you get the tissue, it could be as little as 2 weeks, but it tends to take about a week for that to
Yeah.
So that's why if it's 4 weeks, it's not because it takes 4 weeks to do the testing, it's because it took extra
It
time
takes
to
2
get
weeks
the
to get
tissue.
the tissue and 2 weeks
Yeah.
for the test to come back. I think Foundation is priding itself on trying to get that turnaround time down to like 10 days and not 14.
When they say 10 days, I mean 10 business days, which is still 2 weeks. Yeah.
Paul?
For us, it's 4 weeks from time of order placement.
Yeah.
And it's pretty invariant. I mean, unless there's an issue with DNA quantity, it's 4 weeks.
Do you get any information back before 4
We
weeks?
do. There's an interim thing that says that the DNA quality and quantity was sufficient and it's running. So we get that report to tell us, yeah, that it worked. Alternatively, we'll get a report at about sort of 7 days to 10 days after saying quantity not sufficient, we're not going to run the test.
But you don't get like ALK IHC?
Yeah, we
or-
do. Reflex, we get those beforehand.
You do.
Yeah, but
And
this-
EGFR you get?
That's right.
Yeah.
Yeah.
Marty?
So
How long is unacceptable?
It all depends on the patient. You know, I mean, if you've got somebody who comes in with a large tumor burden, you know, say lots of liver mets, you know, and someone's
wait 4
symptomatic, they
weeks.
can't wait. And so, you know, before the chemoimmunotherapy came out, these were people I'd start, they're always non-squames, you know, I'd use carbo-PEM and wait for it to come back, you know, and I didn't feel badly about that. If, on the other hand, you have somebody who has a small primary and a bunch of little, you know, 2 millimeter nodules, so I know they have metastatic disease, but they're completely asymptomatic, you know, I can wait 4, 6, even 6 weeks. But it's generally, you're almost always going to get it back in somewhere between 2 and 4 weeks. It all depends upon, you know, how quickly the tissue gets from point A to point B.
I find that this is an area where I have to be in constant communication with my pathologists.
But again,
there's
you
a
don't-
tendency to sort of put it off. If I tell them they're coming in the following week and, you know, I really need to, otherwise I'm going to cancel the visit, it's amazing how quickly it comes back.
But again, Corey, you don't have to wait a month for any patient. If they have sufficient burden of disease, you should get it on a plasma test.
Yeah.
Yeah.
Above and beyond that, we're just talking about tissue. So I think we've answered most of these questions. Of course, we can't really speak for the community, but I think the community, by and large, is sending all of this stuff out. Very rarely are they doing a lot of this in-house. I don't know. Do you get a sense that PDL1 is done in-house, MJ?
Well, we do it in-house and it's back in 48
you're
hours.
sort of community
But in the
plus.
community, I see a lot of second opinions from the community. And I'm appalled that still next-gen sequencing is not as prevalent as it should be.
So what are they ordering?
Just their local hospital is doing the EGFR, ALK, and ROS and resulting it and not going
Who's
beyond
doing, are
that.
they doing PDL1 or not?
It varies.
Really? Wow.
Yeah. So it's
But at least they're doing the 4 for the most part, or
Yeah.
not? Okay. We've already talked about who's in charge of tissue acquisition. Main challenges we've certainly gone over. We've discussed KRAS. Should it be done in community? I think, you know, it's part of the package. So if you order next-gen sequencing, it's going to come back. We've discussed reflex or reactive testing. A lot of us have reflex in name only or in partial reality. Again, we've talked about liquid and tissue biopsies and how they complement each other. What proportion of your patients do not have tissue available for tissue testing? Marty?
That's an interesting question, because if I need tissue, I'd send him for another biopsy.
So you will do that, or will you preferentially send off the blood? Or do
Well,
both? I mean,
you can
we've
do
been
bo-
in
I
the
do both,
situation where
you
we
know,
do garden and then we
yeah.
set up the biopsy, and if the garden comes back
know-
before the biopsy takes place and it's
Right.
positive, we cancel the biopsy
Yeah,
to
yeah,
the annoyance of IR. But
Yeah, we've, I haven't had that come up that much. We've generally had enough tissue, but I think I've done that a couple of times. So, yeah, I think sending off both, but getting a rebiopsy, because, what happens, it is also, like I said, sometimes we'll get these people from outside, and the NGS is kind of, or rather not, the mutational analysis is scattered, incomplete, et cetera, and, and then we've picked stuff up.
Paul?
So I can tell you, I just reviewed this for a prospective trial of mine for squamous lung cancer patients. This is purely NGS, first line. 60% had enough material for NGS, 30% it was insufficient.
Insufficient.
So
And 10% were undecided?
that's generally, or sorry, 66 and 33 was the number. So 2/3 had sufficient, a third did not. So I think gives you a flavor.
It's like a poll.
I went to
from
an
NGS
engineering school, yeah.
perspective, exactly how many don't have enough at the upfront setting.
Nasser?
Yeah, that sounds about right, about what we experience.
MJ?
Yeah, similar, but like Mari said, I make the unavailable available by another biopsy.
Yeah.
Our pulmonologist is excellent. His EBUS is almost always enough to send it.
Because
for
he does
next year.
multiple passes, and
Yeah.
they have enough material. So our interventional pulmonary folks have similarly been educated and are very much on board, and they're only too happy to try to get as much. The IR people hit
Yeah.
or miss. Some are enthusiastic, others are always looking for a reason why they can't do a core.
Yeah.
And you sort of learn who to refer these people to. We're closer to 50-50. I think between people refusing another biopsy, or it's inadequate, or it was a FNA and the tissue's not readily accessible, or the IR folks say they can't, it's just unsafe. It's not this 2-to-1 distribution at our place. And we actually have that from our liquid data. So we are completely going out of order. Everybody in the back, for those of you who came in, several of our participants, due to the weather last night, have been unable to get here. They will be here tomorrow. But both Natasha and Tony Wozniak were to talk about EGFR and rare mutations, and instead we're bringing in locally advanced and squamous and small and EGFR today. So Paul's going to talk about slicing the squamous pie, the other lung cancer, the one that nobody pays attention to.
That's okay, as long as I am, I suppose.
Take this away.
So, where's the laser pointer? Let me just see. So yeah, this is, I was telling Nasser, this is one way to, to get at the front. Is everyone else doesn't show up. So this is great. Usually it's the last talk of the last day. So, and now it's the third talk of the first day. So this is Slicing the Squamous Pie. I've given this talk now a few years running, and actually this year there's a fair bit to talk about, so I've had to sort of not talk about some things, but I'll mention them in passing. Corey wanted me to talk about some things specifically, which I'll go through. These are my disclosures in terms of research funding, some ad boards, and honoraria. So what I'd say is that, we always have this talk expecting something like the pie that we normally see for, EGFR or lung adenocarcinomas, where things are sectioned up really well, and so a pie that kind of looks like this for the different fruits, and we'll see what this pie sort of breaks down to and why we don't use the pie anymore for FGFR1, PI3 kinase, CDK, and 2A. But unfortunately, the pie that we're going to sort of talk about now is sort of a meat pie, which is immunotherapy, because of the recent data from earlier this year. So this is the first year that I'm going to actually talk about squamous-specific immunotherapy data, and that's from Keynote 407 and Empower 131. But I will get into some talk about LungMap and the work that we've done on targeted therapy development. So this is the outline. We're going to talk about chemo IO combinations first. That'll be Keynote 407 and Empower 131, and I'll try to go through this data pretty quickly because they are more or less pretty straightforward, except for some oddities with Empower 131. We're then going to talk about targeted therapy in the context of past trial efforts, because sort of our version 1.0 is now done, and then we'll then transition to where do we go next. And I'll talk about some of the newer data that we've collected at Memorial and some of the trial data now that has some preliminary clinical efficacy, things that we can report out that seem promising. When nothing has seemed promising before, as we'll see in the lung map data. So Keynote 407 was presented as a clinical science symposium
Susie's here, though.
in
Susie should be
ASCO.
Corey has his microphone on.
Oh.
At least he didn't go to the bathroom.
I'm hoping. Should we tell him?
Yeah.
Oh,
So Keynote 407 was presented as a clinical science symposium, I think at the same time that Empower 131 was. So I ran over and saw 407. So this is very straightforward. Sure, the companion to Keynote 189, randomized phase 3 trial of single agent Pembro versus dealer's choice chemo, which was either carbotaxol Q3 weeks for 4 cycles or carbonabpac weekly, so Q3 weeks but weekly, for 4 cycles. And then patients could get Pembro sort of maintenance, and for those in the control arm, they just had placebo and observation after that, but could cross over afterwards. And the primary endpoint was PFS. 560 patients provided 90% power for their PFS and OS targets that are shown over there. And this was the clinical characteristics. It was subsequently published in the New England Journal about a month ago now, showing similar things to the actual presentation. Things that are typical for a squamous population in terms of, nearly all patients were current performance smokers. Very few patients were never smokers at the end of the day. And the PD-L1 breakdown, which was shown at the presentation here, was about sort of one of those a third kind of things, which was what we had expected also, based on past data. And it was a positive study. OS was positive, which was sort of the big thing that was announced. This median OS of 15.9 months versus the control median OS of about 11.3 months, which is about what you would expect with a carbotaxol or nab-pac based regimen. The OS subgroup analysis showed that there was pretty much benefit in all of the different subgroups that they took to look at, including PD-L1 cutoffs that were statistically significant, which was also nice to see, and something that reproduced what we had found in Keynote 189, also in the adenocarcinomas. Interestingly, in terms of taxane-based therapy, nab-pac did not perform sort of significantly better than the cheaper paclitaxel. OS by PD-L1 expression was, as I had mentioned before, these were shown during the presentation, but were also reproduced in the appendix for the paper itself, and the data were the same, was positive by about sort of similar hazard ratios by sort of PD-L1 negative patients, intermediate cut point, and then the very high expressors also. And one of the sort of questions here in terms of the actual numerical values is how much of this is a switch maintenance effect to Pembro versus some inherent synergy that's going on, because they get very limited amounts of chemo, right? This is carbotaxol or nab-pac for 4 cycles, and then that's it in terms of chemo. It's not like the adenocarcinomas where the majority of those patients got maintenance pemetrexed in the control arm and in the experimental arm. And so just as reference, I've reproduced some of the second-line data that we have for Pembro versus Dosi and Nivo versus Dosi in terms of what those overall survival values look like, which is sort of generally for the Nivo data about 3 months difference and about anywhere from sort of 2 to 4 months difference. And there is, a decent, I think, hypothesis, or I think one of the ways to interpret it is that especially for the low expressors, this may just be something of an additive or a switch maintenance effect rather than some kind of inherent magic that's there when you combine the two therapies together. Hi, Greg. And so I think that's something to keep in mind, particularly when we, as we go forward and thinking about new combinations for immunotherapy. I don't think we need to be beholden necessarily to this. It is a gold standard, I would say, yes, and I agree, but beholden to this in terms of being concerned about doing a trial that competes like in the first line space for example, like Corey's trial of Pembro plus a JAK2 inhibitor, I think we need to have that flexibility and openness when it comes to interpreting these data.
I want to comment on your comment
Yeah.
of limited chemotherapy. So Mark Susinski had done a trial of limited chemotherapy versus ad nauseum chemotherapy or indefinite chemotherapy, and there was no difference. But the patients in that arm of indefinite also on average got 4 cycles.
Yeah.
So I think the chemo, we can't really call it very limited because
Yeah.
that's all you end up delivering in these
So-
patients.
Remember that study, and actually it is relevant here because that was with carbotaxol, and what the big limitation, why they only got that, wasn't that there was lack of efficacy going beyond that. There actually was some evidence, and it was a small study, and it actually leaned towards an advantage for the longer courses. The difference was they all got their taxane neuropathy.
Yeah.
So I think, let's never forget that the drugs are different, their tolerabilities are different, and cytotoxic chemotherapy is toxic because we designed it that way.
Yeah.
There's no reason.
give
and those
MTD.
were also, I don't remember the Taxol dose, but it was
200.
at least
It was
200.
200,
And remember that they had already backed down off 225. People forget the starting doses, the recommended phase 2 dose for Taxotere was 100, not
Yeah.
75, and probably 60 is where we should be. So a lot of these things with chemotherapy are an effect of the tolerability, the cumulative toxicity effect.
That's
And
right.
in US, actually, it was 100 versus 75 versus best supportive care, the Frank Fasella study.
Similar things we're seeing
No,
with
it
CarboGem
wasn't-
and Maintenance Gem in terms of a PFS
It was-
benefit, but not quite an OS benefit.
Both the US and Canada for the second line started at 100 and then went to 75 because the 100, which was the original recommended phase 2 dose, was not tolerable. And so
Had
they
to be dropped.
both studies went down to that. It wasn't 3 line.
So PFS was also positive in the overall population, 6.4 months versus 4.8 months. And again, all of the subgroups seem to benefit significantly from this, including the PD-L1 cut points. Again, no difference really in terms of the different taxanes that were utilized in terms of clinically or practically what one would do. In terms of breakdown by PD-L1 expression, again, we saw sort of the curves that got bigger and bigger in terms of the gap with higher levels of expression. But again, this sort of concern that you saw sort of more of a modest benefit potentially in those who are low expressors for PFS, which raises the question as to whether or not there's this upfront second line effect that might be going on in terms of the addition of the Pembro here. I've reproduced the response rates here for the PD-L1 cut points. That was not clearly, I think, shown before, but is in the appendix section. You can see that in all of the subgroups, it was higher in those patients who had chemo post-Pembro versus chemotherapy. And the chemo control arm performed about as what you would expect for a carboplatin-based doublet with a taxane. Similar adverse event profiles also, which was nice to see. Here we saw some modest increase in terms of events leading to discontinuation in the pembrolizumab combination arm. And some of this was related to the immune-mediated adverse events. But these were, by and large, what we would expect. And I think the important thing to see was that the frequency of grade 3 pneumonitis was not astronomically higher, particularly because we're dealing with a taxane and there's some concern for baseline level of pneumonitis that's there. So for us, who treat squamous, this was an important safety thing to end up seeing. Otherwise, very similar to what we would expect based on the Keynote 189 data. So that's it for Keynote 407. Fairly straightforward. Worked in every PD-L1 cut point, which is what we'd like to see in terms of being something that's straightforward that we can just enact, is now FDA approved. IMpower 131 was the sort of companion study that was presented at ASCO as an oral abstract. And this was a more difficult study, I think, to interpret. So the overall design was fairly similar in terms of it being a randomized phase 3 upfront trial, taking a look at any PD-L1 patient, but stratified by their various cut points. Here, the control arm was carbo-nab-paclitaxel, and then they had arms A and arms B, which had carbotaxel, atezo, or carbo-nab-paclitaxel and atezo. Here, they could get 4 to 6 cycles of therapy, and the treatment was delivered similarly. The baseline characteristics were more or less the same, and the one thing that I did note was that they pointed out liver metastases again, which were balanced for those who were interested. And this was the investigator assessed PFS in the intention to treat population. So progression-free survival in this study was positive. It was 6.3 versus 5.6 months. Hazard ratio was 0.71. So positive in terms of that primary endpoint. As referenced, these were the PFS values for Keynote 407. It was 6.4, 4.8, so very similar in terms of the PFS benefit in the overall population. There was increasing benefit with increasing degrees of PD-L1 expression that they showed, and we know again for Atezo that they have this combined ICTC score that we have to deal with. For those that were negative, it was not quite statistically significant, though it was trending towards increased benefit, and most of the benefit we saw in the very, very high TC3 or IC3 expressors there. And then here's the hazard ratio for the overall population. And again, I placed the PFS values that we saw. Again, it's sort of really is apples to grapefruits comparison because the PD-L1 cut points are different also. But this just gives you a flavor of what's sort of low versus high, the spectrum of PFS values that are seen, which are sort of similar in terms of an increasing amount of benefit with PD-L1 expression. And this was the subgroup analysis shown in a different way, and the surprising thing maybe was, not really surprising, but they did the analysis of liver metastases that they did with Empower 150, and here, shockingly, it was not better if you had liver metastases. So I don't know what's up with that, but
Maybe it
but
was
there's
meaningless
sort
from
of
the
that
start.
as sort of the thing, although I don't think they emphasized that at the presentation. Response rates also seem to increase with degrees of PD-L1 expression, but interestingly, here in the PD-L1 negative subgroup, there was no benefit in terms of overall response rate, which is a bit different from Keynote 407, yet another difference. And again, I sort of reproduced what 407 looked like just for reference in terms of the response rates that were all better, including in the negative patients, than chemo. So the big issue in terms of the first interim analysis was that the overall survival was negative here. Median OS was 14 versus 13.9 months. This is only the first interim analysis, but this is the big difference between Empower 131 and Keynote 407, which is why no one's using Empower 131 as a regimen, among other things. The other oddity here, when they took a look at OS by the PD-L1 cut points, right, so negative, intermediate or low, and then high, was that there was one group that did worse. Right, so if you were PD-L1 low, you did worse if you got Atezo plus chemo than if you got chemo. Hazard ratio was 1.34. So that's kind of worrisome and something that we can't really explain. And so we're really, I think, going to have to be pretty cautious in terms of further analysis to see how this pans out, whether or not it's just sort of a fluke of the first interim analysis that will right itself on further analysis. But yet another reason why we, I think, have to be cautious about this, and yet another reason why, for some reason, pembrolizumab seems to be more straightforward in terms of the first-line data than some of the other PD-1 and PD-L1 inhibitors that are there. One of the things that was interesting to see that they had presented for the Empower 131 was the proportion of patients who got subsequent therapy. And here, 40% of patients got, just 40% in the control arm got subsequent IO of some kind. And that is a sort of big difference than what I might have anticipated in terms of those folks who would have gone on to get to IO. So again, a heterogeneous population when it comes to trying to interpret overall survival. So in conclusion, I think taxane plus carbo plus pembrolizumab is the first-line standard for advanced squamous lung cancer patients. There's no difference in terms of OS PFS for Taxol versus nab-paclitaxel. The big difference is the money. Nab-pac, of course, is much more expensive. It's also more difficult, I think, to give in terms of that weekly nonstop chemo that they get as part of that regimen here in a Q3-week cycle. I do think we need to wait on further interim analysis to make heads or tails about what's going on with Empower 131. And again, I think there's this question about switch maintenance pembro. We used to talk about switch maintenance before in the chemo days, and I wonder whether or not we're seeing this effect in squamous lung cancer patients as well, particularly in the PD-L1 low expressors. Just to say that, again, we should not be beholden to this, I think, if there's a good trial that's around there in the first-line setting to be flexible to including squamous patients into that. So that is it in terms of Empower 131 and Keynote 407. So we're leaving behind the meat part of this, and we're going to talk about the different fruits now for the pie chart. Targeted therapy, circa 2018. So I had shown this last year also. There's a minor update in terms of lung map, but these were basically what we had thought the pie chart looked like, which is actually not accurate at all. But what we thought it looked like back in 2011, 2012, when we were constructing the pie chart for squamous lung cancer, high-frequency PI3 kinase alterations, FGFR1 amplification, G1S checkpoint alterations, and then this is something that I've been interested in, which are NFE202 and KEAP1 mutations, which we'll talk about in a little bit. So we had constructed a bunch of trials around these targets, and they're all negative. All of them have read out both in terms of industry efforts as well as lung map, and I'll show the lung map slide in a little bit. And we tested a lot of different drugs, lots of FGFR inhibitors, lots of PI3 kinase inhibitors, a couple of G1S checkpoint inhibitors, and they were all uniformly negative in terms of PFS and overall response rate, which I've listed here, just to show some of the industry trial results that we were part of. And this was again reflected in lung map, and this is something that Valley had presented earlier this year, showing the results of a few of the different initial lung map squamous arms for PI3 kinase alterations, FGFR alterations, and what you see is response rates that are also really quite low for targeted therapy, in the single digits for most of these things. And then really, I think for me, the take-home message is the PFS values for these are exceedingly low. So you can make the argument that maybe if the response rate is relatively low, maybe that's okay, because we don't quite understand the biology. Maybe there's some kind of static effect, and if you get this very long PFS benefit, it's still telling you that the pathway is operant and functionally important in a way that you can target, but we're not seeing that at all in terms of the PFS benefit either. So really that first generation of trials was solidly negative. This is the current lung map status, which Corey had asked me to show, and this is a little bit busy because they include a lot of the negative trials that are completed. This is just for reference, I think, to have as part of the slide set, but also some of the open and ongoing trials in the biomarker-driven studies, and there's one that that's being headed by Taufik and Laura Byers, taking a look at sort of loss of heterozygosity for BRCA1 and rucaparib. And there's an ongoing one also for an ADV compound, and then some immunotherapy things that folks are playing around with still. But really, lung map is looking for the version 2 kinds of concepts for new targets or new ways of targeting these things. So why is it this case? Why have these trials failed at the end of the day? And I think there are probably a few different non-exclusive reasons as to why this is the case, some of which we'll get into in a little bit. One is that the putative driver events are, in fact, not driver events at all. We're just plain wrong, in other words, in terms of attributing functionality to these things. The other possibility is that the drugs have not been potent enough, and that may be the case for FGFR inhibitors. And the other, of course, is that the tumors are more complex, that there are these bypass pathways that are already present that we're not accounting for that impede having a response to sort of single target inhibition. So one of the things that we showed in terms of the driver not being the driver, probably in the majority of cases, is from the AZD4547 FGFR inhibitor trial that I was a part of, that we published last year, which is that AP11 amplification, which is the amplicon where FGFR1 sits on. We thought this was amplified in up to 20% of patients. We thought this was really all about FGFR1. But the data that we showed is that most of these AP11 amplifications are probably not FGFR1 focal amplifications, that it is a sort of a relatively narrow peak, but that there are lots of genes that are there where there's fracturing, as I'll show in a little bit. And just to review the clinical results, we saw very few responders in the trial, 13 evaluable patients, 1 responder in this case. Median PFS was also something like 2.5 months for this trial. We did have NGS and RNA analysis for a lot of these patients, which was nice, and one of the unique things I think about our effort that we analyzed in-house at Memorial. And what we showed was that there was a fair degree of heterogeneity in terms of taking a look at amplification in AP11. And so the way to take a look at this is that these are the genes in the AP11 amplicon ordered from centromere to telomere. And then I have highlighted here the multiple FGFR1 probes. And right off the bat, for the FGFR1 probes, you see there's a lot of heterogeneity. There are some that have amplification, some that really don't, and most, at the end of the day, don't really have amplification. We included some control lines that are known to be amplified and responsive to FGFR inhibitors, and that's that broad red that you see here in the amplicon, and then we have some negative control cell lines. And a lot of these look pretty much like the negative control cell lines, despite the fact that we're detecting amplification by FISH. And a lot of these don't have amplification as evident in the RNA, again suggesting that there's a great deal in patient samples of heterogeneity AP11 amplicon that just using that as a readout is not going to capture the truly amplified patients. So there is another reason for failure that's fairly obvious, which is that the pi is just simply not accurate, that there's non-overlapping drivers that are present. For adenocarcinomas, might not be the case for squamous lung cancer. This is an alternative way to take a look at the pi, which is the OncoPrint, which shows sort of lots of different putative oncogene and tumor suppressors. And you can see that there's a lot of overlap in individual patient samples here. And if we're not accounting for a lot of this heterogeneity in tumors that are relatively complex, then we may very well be missing something. And I do think that that's probably part of this as well, leading to this question of, how exactly do we target these things where there are lots of putative drivers? And here we've only tried to do single target inhibition. We've not ventured into targeting two different pathways, but I do think that we're going to have to buck up and try that at the end of the day to see whether or not we're going to be able to make some headway. I think the problem here is that a lot of the inertia has died out in terms of doing trials within this space, particularly for drugs in development, so I think that's going to be a challenge. So what are the future directions? Well, certainly we need better preclinical models because we have very few preclinical models in squamous lung cancer. So that's the first thing, to be able to play around with in vitro and in vivo studies. Again, talking about single target, single drug paradigm is something that's ancient. I think that's something we're going to have to get beyond. And it may mean looking beyond sort of discrete genetic alterations as drivers and taking a look at how they might impact the immune microenvironment. And that's something that we're working on in a similar fashion to what, for example, Corey's looking at for JAK2 in terms of altering the immune microenvironment as something that happens within the tumor. So the one thing that I wanted to talk on, this is the last thing I'm going to talk about, is an effort that we're doing taking a look at a pair of redox genes, NFE2L2 and KEAP1 mutations. And I think I'm running short on time. But these are alterations that we've known about for some time that happen at relatively high frequencies, at about 20% at our institution for each gene. Part of the reason why they're interesting is because NFE2L2 mutations are hotspot mutations. They only happen in squamous lung cancer and head and neck in a particular N-terminal domain called the NEH2 domain, and only within a couple of different or a few different functional domains within that domain where they encode for the KEAP1 binding site, its negative regulators. So the mutations that happen in this oncogene, putative oncogene, happen only in its negative regulatory site. Its function is, again, in antioxidant response, and it is quite a powerful antioxidant response sensor where it's balanced by KEAP1 as an electrophile sensor. Its transcriptional program involves ROS1 elimination, drug transport, and glutathione synthesis. KEAP1 sequesters NRF2 to the cytoplasm. So in times of oxidative stress, there are these cysteine residues that get altered in KEAP1, which then releases NRF2 for nuclear translocation. These mice that are NRF2 null are highly susceptible to chemical insult, which makes sense based on its function. And KEAP1 null mice, interestingly, die due to hyperkeratosis of the upper GI tract. This is squamous epithelial overgrowth. And they're, again, mutated in about 30% of squamous lung cancer patients. I'm going to quickly go through these things. So we had done a series of in vitro experiments in conjunction with NCI showing that across different rapalogs, and there's data that I'm not showing right now, that NFE2L2 activates mTOR signaling, that the combination of cell lines that have NFE2L2 or KEAP1 alterations in conjunction with TAK228, which is a novel TORC1, TORC2 inhibitor, is the only combination that seems to have a cytotoxic effect, which we then... We'll go over this, which we then show in vivo as well. So this is a LK2 squamous lung cancer NFE2L2 mutant xenograft treated with a number of different rapalogs or TAK228. Rapalogs have no anti-tumor activity, but TAK228 does, both at a relatively low dose as well as a higher dose here, leading to a decrease in the size of the tumor that's fairly prolonged. So we had launched now a couple of years ago an NCIC type supported phase 2 trial of TAC-228 in this patient population, which is expanded now to a KRAS KEAP1 bucket, which I won't go into. And all of these patients are identified through our impact assay. And right now we have 5 patients who are evaluable for response. These are the different NFE202 alterations, all in the hotspot domain, all fairly heavy smokers as we would expect, all relatively old as we would expect also. No unanticipated adverse events. These are very similar to the toxicities that you would see with a rapalog in terms of hyperglycemia as an on-target pharmacodynamic response, as well as some GI toxicity. And the interesting thing are here. So these are the 5 evaluable responses. And for NFE202 mutant lung cancer, again, we have a couple of different cohorts that are there. And we do have a couple of different partial responses. And nearly everyone, actually everyone has some degree of radiographic response at this point. And one of the interesting things is in addition to the responses we're seeing, they seem relatively durable. So we referenced the median PFS of about 2.5 months for the other targeted therapy efforts, for docetaxel, which is about 2.5 to 3 months. And a lot of the responses do seem to be fairly durable. So some early clinical data suggesting that targeting this may have some legs as a potential new target with TAC-228. There's a sort of wealth of fascinating biology about metabolomics that I will not get into that is also behind this, that some groups at UCLA and NYU have done, and that we're beginning to get into as well. So I think there's more to come in terms of this particular target in the future, and that's an example of a sort of response for
Always nice to see.
gastroparenchymal lymph node, which is nice to see. And you'll go through the discussion points, so I won't do that.
Very good. So we're going to have a discussion, then we're going to have a break. So I know everybody's probably ready for one. And Ignacio responded to some of my emails, so I may actually do that as part of Greg's talk. But we'll go around the room first with what is your preferred first-line approach for squamous? Marty? Have you adopted Keynote 407 lock, stock, and barrel?
Pretty much. Well, if the PL1 is above 50%,
Go with Pembro. Yeah.
if it's 0 to 49.9, then I think carbotaxol.
I don't think I've ever seen a
Pembro,
49.9.
is what I would do.
And no NAB paclitaxel.
No, I just don't think that there's any value. There was no value in its phase 3 trial against carbotaxol, and there still is no value.
Yeah, and
It's fun to have the chemo wars.
But it's a pain in the neck to have patients come in that frequently. They don't want to come
It's
in that
weekly,
frequently.
and we're using it on one of the trials, and of course the guy ended up with this rather interesting hand-foot syndrome. It was rather painful, unpleasant. So more toxicity, more expense, and no improved efficacy. It's like protons, except that they have less efficacy.
The NAB pack or the protons?
Both.
Paul?
Protons.
So I'm the same way. I think the exact same way, and I think hopefully most people end up being the same way. So one of the things that I will say is that one of the things I didn't get to talk about, which I touched on last year, was we have this phase 2 trial of first-line NAB-PAC plus gemcitabine that's now finished accrual. And
First line.
Yeah, and we're writing the manuscript now. And it's a good regimen. The overall response rate is 60%.
60?
60. Median PFS is about 7.5
Carbotaxol
months.
does that from time to time
This
too, right?
is
Dr.
in a
Williams?
PD-L1 sort of negative or low population.
So this was specifically, but you
With-
started
with-
this in the,
Sorry?
before the
We
Keynote
started this
407
before
came
Keynote
out,
407,
right.
yeah. and so
gemcitabine
fortunately,
plus
plus
pembro?
nab-paclitaxel. So
Just the two drugs.
Basically
No.
the pancreas
the
regimen.
pancreas regimen,
Right.
but given in a
With-
Q3-week cycle.
With immunotherapy? Or
No,
just
no
two drugs?
immunotherapy. This is just
Straight
chemo.
chemo, Marty.
regimen.
So the reason I mentioned this
that
only
lousy taxane.
is because just I think the ways to make improvement in the first line space are you either make the chemo better or you make the IO better. And I think this is a area that that still is something that we can potentially make some.
Are you
gains on.
thinking of combining IO with that combo?
Yeah, so I think Celgene, who's the sponsor of the IIT, they're still confused as to what they want to do with their Vigene compound. I think they're focused on stage 3 right now. So I'd like to do that, but at the end of the day, if we're able to get this on the NCCN, then we can do it ourselves.
How many patients did you have on the phase
This was
2?
30 evaluable patients, so it's a decent
How long
size
did it
for a
take you to
single-arm
accrue?
phase 2. We started in 2015 and
Not bad.
finished, So
And this is strictly squame,
strictly squame.
and no squame. I mean, it's
No,
essentially
strictly
squames. And these were, by intent, low PD-L1, because if they were 50% or higher, you
Yes,
would have
they
given
got
them
Pembro. So
Yeah.
they're either unknown or low PD.
Okay. Nasser?
So a couple of comments. So to answer your question directly, same thing. 50% or higher for PD-L1, they'll get pembrolizumab. If they're less than 50% carbotaxol, pembrolizumab, I wouldn't give nab-paclitaxel. I'd like to see carbo-gem with pembro, just because alopecia is an issue for some of our patients. But the two comments I wanted to make, when we started to see the results in the non-squamous population with the PD-1 inhibitors, the real excitement is that there's a nice tail of that survival curve, and we're seeing patients who are 3, 4, and 5 years out. I think the disappointing thing from the Keynote trial is that there's not that same tail.
Well, it's
That-
still a little
It's still a
early,
little
though.
early, I think, yeah.
Yeah, the
Well, you have a lot of
directions.
slides here,
I
Paul.
know, sorry.
I think you had I just want to look at the tails again.
Yeah.
So,
We'll-
no,
we'll-
this
we'll
was,
see.
It's
There's no
Empower
tail there.
131.
yeah, no, we want to get back to the Keynote.
Yeah, well, actually, if you go to the PFS curves, it's
Well, here's OS. So I mean, most of these, it was a very early analysis.
it's an early analysis.
And the high group, both groups are having a tail, for what it's worth.
Yeah, the other thing I wanted to mention, and I agreed with Paul on, is it a switch maintenance effect or not? The one thing that gives me pause about that is that the response rate is so much higher with the chemo immunotherapy versus chemo in the PD-L1 less
It
than
is,
1%.
but even that may just be additive, right? You add on single agent pembro response in those patients, and you'll get probably, you get that much in the second line setting, right? For Nivo, it's 20%. So I think there's probably some additive thing, yes, during the chemo, but in terms of the PFS benefit, I think it's no more than you would expect if you sequence them directly after finishing those 4 cycles to pembro.
Yeah.
For example.
And then the last thing I want to say is that, the frustrating thing on the Keynote trial is they didn't provide any TMB data. And that was the advantage that at least we saw with the Checkmate trials in the patients who were PD-L1 less than 1%. Is if you were in that subset, it did seem like immunotherapy outperformed chemotherapy.
To get
And so if we're looking at a group of patients who not to give chemoimmunotherapy to, it would be nice to see on the Keynote trial the TMB high
I don't
versus
think TMB
low.
was even thought of at the time.
No, it probably
Wait,
isn't, but
in the
it doesn't
trial.
mean they still couldn't do the analysis. So, in that PD-L1 less than 1%, if we could look at, and even in the other groups of patients as well. But having said that, in the absence of ever getting that, I think you just give it to everyone unless they have a contraindication to the checkpoint.
Greg?
Nothing good to add. I would just echo what Nasser said about I'd love to see some GEM
GEM
regimens.
data,
Because that's, my go-to squamous regimen was CarboGem, CysGem before, and I'd like to add some
Warms
immunotherapy.
my
there.
heart.
Yes, two big gem proponents here. It's amazing how the temperature of the room can change depending on what people use. So I'm the lone user of NABPAC.
Way to stand up. Be proud.
Although I've used PAC. My patients don't seem to mind coming in weekly, unlike
nice
yours.
guy.
They do mind having neuropathy, which is still a feature of 200 per meter squared, and relatively less a feature of NABPAC. My nurses like giving something over half an hour without steroid pre-meds. And for what it's worth, the response rate was higher in that trial, for what it's worth. Also, these patients tend to be a lot older, certainly older, and you showed that in your own series at Memorial. And
And it's
again,
nice. It's nice
certainly
not
no
to get
worse
the-
than standard PAC in that setting.
It's nice to avoid the hypersensitivity reactions.
It's
Those
nice
are-
to avoid it,
those are a pain in the neck.
particularly since one of the 2 calls I just got that you guys overheard was about a hypersensitivity reaction on Paxing. So these things still occur. We're all wedded to IOs and targeted therapy, but we're still dealing with prosaic stuff like HSRs on taxane. So it's I'll probably unless I am expressly prohibited from using it because of the cost, which to me is the only major issue. And at the end of the day, I think the major deterrent to using it I'll probably stick with it. But it is actually on our pathways. Probably we're the only institution that has it on a pathway. Paul, I think you covered this. What genes should be tested? We point to the lung map as a negative trial, but I don't think we could have accomplished that sort of trial without at least the infrastructure of lung map. And your thoughts on, granted, things haven't panned out. Marty was the PI on one of those failed arms, and I'm the PI on another failed arm, and we're trying to put this together as
I think
a packet.
yeah, yeah. I mean, it's taken forever, but a few of the things are just we may not have had the right markers. I mean, certainly that was the case in the cell cycle. Because both responses that we saw were in the CDKN1 group, and maybe if we had restricted to that and had more patients, and there were a lot of them, we would have hit our requirement to go to the second phase of accrual. And Palbo by itself is not that effective in breast cancer. We just may have not had, there are just issues in design. I think it was, I think the good aspects of lung map are the rapidity of accrual, the fact that you can do these studies in a modular way and quickly answer the single agent questions. But part of this may be the markers and just getting more sophisticated about stuff.
Yeah, so I am the sort of ongoing right now beneficiary of lung map insofar as I'm talking with the lung map team, Valley and Roy, about adding an arm for the NFE 202.
To adding this specifically based on what your phase
Yeah, based on
were.
sort of a newer iteration in combination with chemo, actually.
Yeah, that looks rather exciting.
And so
Certainly
we're-
better than what Marty and I have seen
Yeah,
on
so
our two
we're
arms.
we're undergoing discussion, but I have to agree with Marty. I mean, the great benefit is that, so first of all, we needed to do those trials, right? I mean, you need to do single target, single drug based on the preclinical sort of data. And so we needed to get those out of the way to sort of show whether or not that worked as a strategy.
We really had no idea whether it
Yeah,
would work
that's
or not
exactly
a
right.
priori.
And we had a lot of hope that they would, because you look at the adenocarcinoma experience and it's great. But I think now, we're going to see the benefit of that existing infrastructure that's there, with all of the sites ready to go in terms of new iterations of trials that will come on board. So.
How is this drug given?
Sorry, oral.
It's all oral, and it's
Yeah.
a typical TKI type.
It's a typical sort of Rapalog TORC1, TORC2 inhibitor in terms of toxicity. Yeah.
So a little hypertriglyceridemia, a little weight loss, a little dehydration. But these are very small
But
numbers.
yeah, it's five.
Yeah, it's five
patients.
patients. They have a much larger, TAC228's been studied a lot. It's in an NCI match right now for a couple of arms. And so the toxicity profile is fairly well.
You don't really have
vetted
anybody
out.
with primary progression here. You have one guy
No.
with pseudo-progression,
And
then he
that's
actually
the
had a
interesting
response.
thing about this. For the NFE 202s, there's no primary progressor. That's right.
So have Roy and Valley taken this up in the...
Yeah, I think they're interested. The issue right here is we're waiting for Takeda's formal buy-in. Because as I mentioned
Why wouldn't they want to
before-
buy in? I mean, we've got a ready-made infrastructure
know.
with tons of
It's-
patients that are just... And what's the prevalence again? You said
Right.
30%?
Yeah, so combined, it's about 15 to 20% for each gene. I think the issue here is the development, where the drug falls in its development cycle is a bit late, and it's those kinds of issues that are there. So
MJ, any thought? We went around the room with the preferred first-line regimen. Is yours 407?
Well, pretty similar to what was being said. You obviously now incorporate immunotherapy with it. I am not a big fan of taxanes in general.
So you're another GEM user.
Yeah, I'm a GEM user.
Wow, 3 to 3.
Lined up nicely here.
And not a big fan of NABPAC.
No. I mean, why would you
5
give
to
a
1 on that one.
$10,000 drug when you can give a $200 drug?
Okay. So again, going to your whole presentation, Paul, how critical is the concept of driver mutation in squamous? I mean, we certainly have put that forward in non-squamous, and it seems to be operative, but it doesn't, maybe here, but probably
So
not.
I think the issue here is we're a little bit hampered by the fact that the models that we've had have not reflected what's the clinical experience has been. I think we just don't have enough models to play around with. We certainly don't have enough transgenic models to play around with in this setting. So I think we're limited with regards to that. For me, I think part of the shift is in reconceptualizing these potential oncogenes in terms of the role that they might have, again, in immunomodulation, or in terms of metabolomics. And again, I didn't get to touch on that data, but it's an interesting vein that's there that I think has some traction also, dovetailing with the NFE202 work.
So we do have some additional questions, but I'm going to save these for Greg's talk because they really pertain to EGFR and also back to tissue. And I'll also talk about some of the answers that Ignacio gave me to my questions. But any other comments about squamous? Anything you're doing uniquely, MJ?
Seeing less and less of it is what's new.
Less and less, Greg? They're not going away, though.
Yeah, I think this notion of driver oncogene, I think this is the question. You know, is this only applicable to half of lung adenocarcinoma and the rest of it is something else? I think maybe.
Nasser?
You know, my and perhaps misguided impressions or the way that I've thought about squamous cell cancer has been sort of why I think small cell lung cancer also doesn't tend to respond to targeted drugs, is that there are so many tumor suppressor genes that are abnormal in squamous cell, and there's so much genomic instability. And I wonder if over time the things that are appearing to drive the cancer change. And I don't know if it's more genomically unstable compared to a typical adenocarcinoma, but my impression has always been that there have just been more tumor suppressor genes that are abnormal.
Paul? Anything to add? I think you,
No, nothing new to add.
nothing novel.
You know, I'd agree. I mean, I think that these are the tumors that just occur in people who are heavy smokers. There's lots of redundancy in the system, and you know, if you think about it, the driver mutations are present in the 15% or so of adenocarcinoma, and that's where and almost not exclusively, and we've made a big deal, and it certainly show up occasionally in the smokers, but the reality is you can pretty much bet who's got it and who won't, by demographics, and therefore you'd bet fairly heavily that these people aren't going to have that. Lots of mutations. Those passengers can take over the steering wheel on any occasion, and let's face it, even in the oncogene-driven tumors, their time on our most effective targeted drugs, the median is about, on a good day with osimertinib, it's 16 months. Most of the others, I mean, that's the medians.
The days are getting better. It's
They do
18
get
months with
better.
OCM,
Maybe it's
maybe
18
close to
months,
3 years
18
for
months,
a lot of
whatever. And clearly there are some people who are quite durable, but the vast majority of patients will progress, and those are things that are two logs simpler than the other diseases.
With that, we're going to have a 12-minute break. We have 2 additional talks. Greg's and Nasser will be introducing us to Locally Advanced at the end. And then we'll pause for the rest of the day. Thank you.
It's the ALK positive section.
Your clinic, we heard?
Yeah.
We're a little bit out of order, but Greg's going to go next. He will discuss EGFR mutant non-small cell, an area that he probably, I think you eat, breathe, sleep, and drink this all day long. He'll talk about new directions. So it'll really be a focus on some recent data and where we're going, I hope. And we'll resurrect some of the questions regarding T790 at that point.
Yeah.
Okay.
So I thanks for having me, Corey. I think this is a nice opportunity, and mainly what I'm going to show you is data that you guys all know, but just to remind you of the data so that you have it in your head as we have these discussions. So we'll jump in here just to remind everybody of the different generations of EGFR tyrosine kinase inhibitors and how they all compare. And I think the key thing is they all hit the sensitizing mutations, the LA58R, the exon 19 del. Where they have differences is really their coverage of EGFR T790M, as well as their coverage of wild-type EGFR. And of course, this is a bold overstatement saying that there's no activity on wild-type for third-generation EGFR TKIs, but nonetheless, there's much less, significantly less. And I did include on this list nazartinib, which is EGF816. It's now got a name. And this is the third-generation drug from Novartis. So before we jump into third generation, though, we have to step back for just a moment and remind ourselves of dacomitinib. Did I Did I make sure to include dacomitinib's included here as one of the second-generation drugs. So one thing that this table doesn't show, which it should, is that second-generation drugs also have some activity against HER2. So they can inhibit that kinase, and that's part of what makes them second-generation drugs. And dacomitinib is one of these drugs. And this is the data from Archer 1050, I think is what it's called. And this is a randomized trial that compared gefitinib to dacomitinib. And we had previously seen data on progression-free survival, and this year we've seen data showing overall survival. There's some statistical tomfoolery here in that this wasn't necessarily a primary endpoint or maybe even a high secondary endpoint, but this was analyzed, and it's survival, so there's not a lot of bias involved in that. But what you see here is that the dacomitinib arm did better than gefitinib, and gefitinib isn't a drug that most of us were using, so showing that something is better than gefitinib is probably not that provocative. But I think when you look at the overall survival data, showing that 34-month median overall survival for dacomitinib, I think that's pretty impressive. And the way I've sometimes summarized this, and pardon me if it offends anybody, is this new drug you'll never use is better than the old drug you never used. So I think that kind of summarizes it. All right.
Yesterday's drugs today. Yes.
All right. So now
We'll
we'll move
get
on
there
to
during the discussion.
we'll move on to another iteration of using first-generation compounds, and this is gefitinib added to chemotherapy, and this is a trial done by the Japanese, the Northeast Japan study group, and they compared gefitinib monotherapy to combining gefitinib with carboplatin pemetrexed. And this is the design of the study, relatively straightforward. Not much to say here, except that the kind of the usual thing. You get 4 to 6 cycles of platinum-based chemotherapy. You continue on maintenance pemetrexed. So a lot of chemo given in that maintenance phase, given how long these patients do well on gefitinib. And this is the overall survival curve, showing us that giving chemo plus gefitinib improves overall survival compared to gefitinib alone. And I think another takeaway from this, which is kind of mind-boggling really, is that those median overall survival numbers, 39 months for patients who receive single-agent gefitinib, 52 months for those patients who receive the combination of chemo plus gefitinib. So this is really a tremendous difference. But again, the gefitinib arm is way better than the gefitinib arm I just showed you in Archer 1050. So I'm not sure how these two necessarily compare.
Pem was just, it was not given as maintenance.
It was.
It was given.
Yeah, so this is the schema here, and there's a maintenance phase so patients were getting a lot of pemetrexed. Okay, do I have the progression? I skipped the progression-free survival curve. So we'll jump now to third-generation drugs, specifically osimertinib. Reminder that the mechanisms of resistance to first and second generation EGFR TKIs are relatively broad, but a peak among the T790M. So T790M, probably about 60 to 70% of patients have T790M as a mechanism of resistance, but there's a whole smattering of other stuff. Particularly, I'll highlight MET amplification. There's also HER2 amplification, and then small cell transformations. And none of these are mutually exclusive. They can all happen on top of one another. So we know that osimertinib, the first third-generation TKI available, is better than chemotherapy in the context of T790M positive resistance. This is the AURA3 trial, and this has showed that improvement in progression-free survival for patients who got osimertinib versus chemotherapy. But what we are probably more focused on is the first-line context, and this is the FLAURA trial. First-line AZD9291, so osimertinib versus the standard of care, gefitinib or erlotinib. And I think most of us know these data. This is the progression-free survival curve. You see osimertinib is clearly way better than gefitinib/erlotinib. None of us, I think, were surprised that it was superior. I think the question is how superior was it going to be? And having a 19-month median progression-free survival, I think most of us found that pretty impressive, and thought that was probably reason enough to make this the standard first-line EGFR TKI. This is provocative. This is an early analysis of overall survival from this first-line osimertinib trial. It shows a nice hazard ratio of 0.63, a very small p-value. This p-value is not significant because a certain amount of p-value was allocated for this analysis and it didn't meet that. But nonetheless, I think this is provocative, and I think it's when you add it to the clearly improved data in progression-free survival, it really cements the fact that I think this is the standard first-line EGFR TKI. So we'll move to resistance to third-generation EGFR TKIs. This is a structure diagram of C797, which is where the tool compound WZ4002 binds. So all of these third-generation EGFR TKIs bind to this C797 position. And from the original description of these molecules, people said, you know, we're probably going to get mutations in this site when patients become resistant. And lo and behold, we found that time and time again. This is some recent data. I stole this slide from Charlie Rudin, who presented it at ESMO when he discussed mechanisms of resistance. There's a lot of data here. On the left side of the red line are mechanisms of resistance to first-line osimertinib, and on the right side of the red line are mechanisms of resistance to second-line osimertinib. And of course, the key difference is what's in the light blue color, which is that T790M is present in patients who get osimertinib as a second line, whereas T790M is not present in first-line osimertinib use. So the interesting mechanism of resistance in the second line of loss of T790M is not relevant in the first-line setting and not relevant for what we're thinking about going forward, but it's very interesting that 50% of patients have essentially clearance of this T790M positive clone by osimertinib. This, I should also highlight that the left side FLORA data, that's first line, AURA3, that's second line randomized data, and then the two other series with authors' names are retrospective series from MD Anderson, Moffitt, and MGH.
Before you go further, T797 was not seen in FLORA?
So EGFR mutation is this.
Oh, so it included that.
Yeah,
okay.
so, and C797S as well as position 724 are the two most common mutations.
And what were the percentage that retained T790 in the second line? Is
So-
that also included
So
on the
it's about
EGFR
50-50
mutation?
that retain it, exactly. And then I think probably the EGFR mutation line, the first line of acquired changes is one that we're paying attention to because it's relatively high rates in the second line, but also a significant rate in the first line setting. MET amplification really stands out as a mechanism that we've observed in the first line setting, and first line with first generation EGFR TKIs, and we continue to see that as a potential mechanism of resistance. I will caution everybody that, you know, you see a fair amount of MET amplification at diagnosis. So not all of this is acquired, but certainly some proportion of it is acquired. And we'll come back to MET amplification in just a moment. The other thing that, you know, I'll mention, since I've seen more than a few of these, is fusions, particularly BRAF fusions, RET fusions. These, you know, we traditionally have not observed overlap of oncogenes. And so if you had an EGFR mutation, you were never going to have another oncogene. But in the context of osimertinib, and I think a little bit with first-generation EGFR TKIs, we are now seeing more where patients develop other oncogenic drivers. And so RET fusions, BRAF fusions occur. We've also seen a handful of patients with KRAS mutations. And so this non-overlap of drivers in the resistance setting is breaking down as a concept. Last thing I'd highlight is that we've heard a lot about small cell lung cancer transformation. That's been kind of a theme for probably 10 years now in resistance to EGFR TKIs. We now are seeing that you can have squamous cell lung transformation. So Dr. Pack is now, you know, he's in the oncogene world.
I'll be an EGFR expert also.
That's right, that's right.
So my question there is it really a transformation or tumor heterogeneity?
I think the word that one of my colleagues, Charles Sawyers, studies prostate cancer, and this occurs. This sort of adenocarcinoma to small cell transformation occurs in prostate cancer as well. And the term he uses, which I like a lot, is something called lineage plasticity, really reflecting that it doesn't actually just transform. It's not a one-way street. These are complicated things that are happening in a cancer cell, and things can go back and forth, and we see they just look funny. That's sort of my take on it.
Because in breast cancer, tumor heterogeneity is a real phenomena. I just saw a case of HER2 positive, responded to neoadjuvant therapy and has bone metastases. I biopsied it, that's HER2 negative by FISH. So she, of course, had two populations of cells in the tumor. One got eradicated, the other metastasized. So I think that could be happening in lung cancer as well, mixed histology. And one gets eradicated, other grows.
Yeah, I think that's certainly potentially the possibility. I think, I still am kind of stuck on the notion that these tumors continue to have EGFR mutations. So it's not as though that was a separate clone that had small cell and a separate clone that had EGFR mutant lung cancer, and you cleared the EGFR mutant and small cell grew out, because they still both have EGFR mutations. And so based on that, I feel like it is one original clone that's just kind of behaving differently under selective pressure.
So then why, if it still has EGFR mutation, that's somehow no longer the driver?
It may not be the driver, or it may have a mechanism, a compensatory mechanism that allows it to get around the drug. So this slide is probably not readable and probably not interesting, but it's here to remind me that a lot of this data I just showed you, which is here, so FLORA and AURA3, and a significant proportion of the retrospective data, is based entirely on plasma specimens. Plasma specimens are awesome. You can get them. It's really easy. But you're missing part of the story. And if we're only looking at plasma, we're not going to have the answer at the end of the day. And so, we don't see squamous cell transformation if you're just looking at plasma. And if you can have an argument about the value of plasma because it integrates all that's happening in a patient's tumor. But there are plenty of patients who don't shed DNA, and we aren't able to assess things. This is like one of those pinwheels that you just stare at for a while, and then your eyes start to cross, and you get a little confused. And this was my attempt to try to capture the idea that I think going forward, we are going to do combination therapies, and we're going to do combination therapies that are specific to various pathways, so AXL inhibitors, MET inhibitors, HER3 inhibitors, but we're also going to do combinations with general things like chemotherapy, immunotherapy, bevacizumab, and then we are going to develop some new EGFR TKIs, and so all of these things are here. So I wanted to, so since I've said combination therapies are going to be part of the deal, I wanted to show you some data that I think show us that combination therapy is A, possible, and B, can be effective. And that's really focusing on MET. This is, I'm going to show you two data sets. This is a trial that used gefitinib and capmatinib. So capmatinib is a MET inhibitor. Gefitinib, of course, is an EGFR tyrosine kinase inhibitor. And this is a trial that, go back to the schema here, this is a trial that took patients with EGFR mutant lung cancer. They'd gotten an EGFR TKI. They had MET amplification as a mechanism of resistance to an EGFR TKI, and then they treated the patients with a combination of EGFR TKI and MET inhibitor. This is the data. It's really hard to look at because they've chosen to really break down which patients had which copy numbers and how much IHC, and it's very complicated. But I think the point I would say is that we can combine these drugs, so it's doable, and it can be effective. We see a significant response rate here, and I would remind us all that we saw trials long ago where patients got combinations of gefitinib and crizotinib or erlotinib and crizotinib, and we all dismissed them for two reasons. One, they were toxic, and so we couldn't give full doses of both drugs. And two, we showed no efficacy. And the reason no efficacy was there is because we didn't select patients for those patients who had MET dysregulation as part of their mechanism of resistance.
Are they going to repeat the study with osimertinib now?
Well, I'll show you other data that uses osimertinib. And so this is osimertinib with savolitinib. So this is an AstraZeneca-sponsored trial. This is part of the TATAN trial. And this combines quite a few different clinical scenarios, but combines osimertinib and savolitinib, the MET inhibitor. And this is the waterfall plot. I would direct you to the purple bars, because I think the purple bars with a response rate of 33% are particularly interesting. These are patients who got osimertinib typically, progressed, and had evidence of MET amplification, and then were enrolled to receive osimertinib plus savolitinib. And you see the 33% response rate, pretty decent responses overall. And so I think that really tells us that, you know, we're not, the only thing we're adding to osimertinib is a MET inhibitor, and we're doing it in people with MET dysregulation. And while it's a 33% response rate, it's proof of concept, and I think we can move forward with that. Now I'm going to take a tangent to move to EGFR exon 20 insertions. This is a pie chart that is only the EGFR mutations. This is from our institution a few years back, and you see that EGFR exon 20 insertions represent about 10% of EGFR mutations. So if 20% of patients with lung cancer have EGFR mutant lung cancer, and 10% of 20% is 2%. So it's about 2% overall in the pie chart. And this has been, I don't know, as a person who's tested for these things for a long time, this has been like the bane of my existence. You find the patient has an EGFR mutation, and you're like, oh, now I understand what drives the cancer. Oh, but it's this one. It's this one I can't give an EGFR TKI to, this one. And they have the same characteristics, right? They're patients who never smoke cigarettes and all the same sorts of things. So it was always a frustrating thing. But we now have drugs that can target it. This is the data from MD Anderson using poziotinib, and this is the data presented at World Lung. And you see a confirmed response rate of 43%, so clearly effective. This is the safety data. They're significant talks, but when Dr. Haymack presented this, he put it in the context of other EGFR TKIs that have been studied, like afatinib and dacomitinib. So while 60% of patients required a dose reduction, that was about the same as we saw in LUX-Lung-3 and about the same as what we saw in Archer 1050. So this is within the realm of what we are apparently comfortable with, though I
It's
would argue
higher than Taxotere, though, 56%. Grade 3.
It works
Fair.
better than Taxotere in this population.
Yeah, it does work better.
Right, and I guess the only other, if John were here, I'd elbow him and say, you're comparing it to two drugs that we never chose to use because of their toxicity. So maybe we should pick a different comparison, find another one. But I think you can't get away from this waterfall plot. It's an impressive waterfall plot. Good responses, and clearly, since we have not had something in EGFR exon 20, having something is clearly exciting.
Craig, so I think two of my patients are on that slide right there, and oh boy. Wow,
The tox is real.
it's bad.
Yeah.
Really?
What is the
I
main tox?
treated a lot. And
Oh, the diarrhea in one patient was ongoing for 3-4 weeks. It was bad, but again, many
It's
patients
some-
didn't have that.
Right, yeah.
But the PFS is disappointing.
So we're going to discuss that, I think, in
Absolutely.
the context of what else is available.
And that gets to the duration of response, which I think is shorter too.
Yeah, you know, and I think when we're not talking right now about some of the newer targets, things like MET exon 14, HER2 mutant lung cancer, we're seeing more of this, right, where we're getting a lower response rate. We're not getting the 70-80% response rate we get with an EGFR TKI and exon 19 del. We're getting a lower response rate, the 40% range. We're getting shorter progression-free survivals. And, you know, my suspicion is that this is a drug problem. We don't have the right drug. And, you know, poziotinib was not developed to be an EGFR exon 20 drug. This is developed as an EGFR inhibitor. And so the window of toxicity is challenging. And I think that's part of what we're facing, but I think you're absolutely right. And these data, and I'll show you the data for TAC-788, they both show us that this is a target there is some insight that we can do it, but this ain't gonna make me happy. This, we clearly need to do more. So I'll jump to TAK-788. So TAK-788 is a little further behind. Of course, poziotinib was done in phase 1, and it was set aside as a drug, so everything was all set when the MD Anderson group decided to move it into the exon 20 insertion. TAK-788 is a new drug. It was designed specifically to be an exon 20 drug, but it's behind in terms of its development. My disclosure is I'm one of the authors on this study. This is the waterfall plot from the phase 1 trial looking at the doses between 80 and 160 milligrams. 160 milligrams is probably the MTD. But you see that we're clearly seeing responses, and I think that's, again, a powerful statement, shows proof of concept that we can target these patients. This is the meager response data. Really, there's not much. I guess I'd highlight the far right column, which shows 18 patients. 6 of the 18 patients, or 33%, had a response, though not all of these are confirmed, and so the confirmed response rate is certainly lower. But again, this is phase 1 data, combination of multiple dose levels. This is the swim plot showing that a variety of these, or a majority of these patients are still ongoing, so it's still early to make much of this data. And then I wanted to show the toxicity data to show that it has the toxicity one would expect of an EGFR TKI that hits a fair amount of wild type EGFR. And you see that patients get diarrhea, patients get nausea, patients get rash, kind of the usual expected stuff. All right.
Very good. So, I think a lot of the questions that are coming up were addressed by you, but I actually want to approach what Nasser brought up, because I think that was part of our, generally, the responses aren't quite as impressive, certainly not as impressive as OC. And the median PFS, it's like 5, the number 5 figures very prominently, 55% response rate, 5.5 median PFS. And the other drugs we have in this setting are chemo. And maybe not a 55% response rate, but a PFS that probably is as good, maybe better, particularly chemo works better in EGFR mutations. I don't know if it necessarily works better in 20, but there must be data on that. So
I just came from clinic where I was seeing a woman with EGFR exon 20 insertion was quite excited to put on the trial, except that it's now 13 and a half months on PEMBEV.
So she's doing fine.
She's doing fine, absolutely.
So why would she want to go on the trial,
right? Exactly.
Right? Particularly to have diarrhea.
I'll also highlight this patient's clinical course in that she presented to me with a PDL1 of 70%. And so she got a first course of Pembro, which didn't work at all, and then went on to platinum PEMBEV. These are boring slides. You don't need to show those.
So, Corey, so at least for the poziotinib study, I know everybody trashes the drug, saying like it has all this toxicity. We've treated a lot. It's manageable. You do have to dose reduce sometimes, but I haven't had that much difficulty. While I do agree the PFS, was a little bit more disappointing than what we were hoping for, given that a lot of my patients had great depth of response. They'd been pre-treated before on that study. And so there is a larger prospective trial that's looking at second, or allowing first line and second line. And so I think we'll probably see a longer duration of PFS with that.
I look forward to that, the company-sponsored trial. I think the one thing that, we did afatinib cetuximab at my institution, and we're good at managing the skin tox, and we could handle this combination. And I feel like when people out in the rest of the world tried it, they're like, no thanks,
Sure.
I'll pass. And so I think this will be, the company-sponsored trial will really give a good look at how the tox is manageable.
You're
in the
talking
real
about
world.
for poziotinib.
Yeah, yeah.
So the question I have, is it going to just be a straight phase 2 to confirm it? Will it be randomized? What's the plan for that?
Yeah, my understanding is it's a straight phase 2 with the idea of an accelerated approval.
And are there criteria? Should there be criteria? If they match what you saw in the phase 1, phase 2, is that adequate?
Right, that's the real question, right? What's a response rate or a progression-free survival in a single-arm phase 2 that is adequate to say this should be a new standard, this should be available? And, you know, my bar has always been the response rates have been 40+% range. That means a lot to me, particularly if patients have had prior chemo.
So there's no exclusion for this trial, I mean, on the number of priors, or will it just be one prior chemo?
I think that the company-sponsored trial allows 1 or 2 prior lines.
1 or 2? How about other prior TKIs?
No.
No prior TKIs.
No prior TKI, but up to 2 prior chemos. What does everybody else think? I mean, the question that comes up here is, if it's approved, presumably it will be at some point, would you use it, and what would your criteria for use be? So we'll go around the room. We've heard from one of the experts, Anne.
Well, as I mentioned, we really don't have very much in this space, and I know we didn't really talk about the exon 20 insertions for HER2. Poziotinib really works well, and what I do like about Pozi is it does appear to have CNS penetration. And so we have very limited options for those patients with exon 20 for both HER2 as well as EGFR. So at least this is something, I agree with Greg, I think we need to develop better drugs, but for right now, I think that this is a good option for these patients, and I would use this before chemotherapy.
You use it ahead of chemo,
I would.
despite all the diarrhea. And
Well, but we have different experiences,
okay,
so.
maybe Texas is kinder to these patients. I don't
Well,
know.
I do dose reduce.
Huh?
I do dose reduce,
Well, I imagine
and I do
everybody
empiric
does it.
antibiotics for the skin.
MJ, what's your criteria?
I was going to ask along those lines, this toxicity was, of course, inclusive of dose reductions. So what percent patients were dose reduced?
So in the Pozi data, it was 60% dose reduction.
And 55% grade 3/4 despite 60% dose reduction?
Well, but
No.
typically, reason you dose reduce is because they have a grade 3 tox. Right?
Yeah. All right, so will I use it? I guess we are treating these patients in a palliative setting where nobody gets cured, so I guess we use everything. We have a limited number of bullets to fire, so we use all of them. The question will be where. That'll be trickier. You know, if I'm faced with a patient who has had chemo and has this mutation, is second line, I'm thinking in my mind, should I try a little Gemzar or this, or a little Nevilbene or this? And can
For
I
second line, I don't think there'd be any question. Would you use it front line?
front line? I would be reluctant just because of the toxicity when chemo works in these
So
patients.
you would do the PEM carbo or PAC carbo, bev, rat, some sort of combo.
Some kind of chemo doublet, yeah. I don't
My
use.
question for you, Greg, how many of these folks were chemo exposed prior?
Oh, I think everybody in this trial.
Everybody.
Yes,
Okay.
we have
Yeah.
multiple
Okay.
lines.
And a significant number of them had
So we were
prior
seeing a
EGFR
55% response rate in essentially a second line or
Yeah.
third line setting.
TKIs. Yeah.
But the other trial, I presume, will be first line, right? The straight phase 2.
The straight phase 2 will allow some first line, but I think it'll largely be focused on a second line context.
Yeah, but if I see first line data, then I could be more
I don't
convinced.
think you're going to see 55% response rate with any second line regimen.
But I think
In
this
this
is
It's
setting.
not
like
just the response rate, you know, it's,
Wow.
this is like the dabrafenib trametinib data, right? You know, this is in its efficacy. We saw the dabrafenib trametinib with a 60-ish% response rate in the second line.
PFS was about 9 months.
Right.
So.
And people, I think mostly are comfortable moving down to the first line, though not everybody is.
Nasser? First, second line, what's your cutoff?
Second line, I would think, and, the toxicity, what I'd like to see reported in general on studies is not just the grade of toxicity and the number of patients that are dose reduced, but the duration of the toxicity as well.
So you want an area under the curve.
Yeah, because
Maybe under the diarrhea
that's what
curve.
happened with afatinib is, you start using it at 40 milligrams, which is the FDA-approved dose, and not only do they get the diarrhea and the rash, but it will last for like 2 weeks after you've held the drug. And so that makes a bigger impression on you as well. So, I mean, I'd like to see that. I've never personally given the drug, both of my patients, and again, it's dangerous to remark on 2 patients. I sent to John, and John treated both of them. And both of them came back with a response and in a wheelchair.
Because of the diarrhea. Okay. And it's not trivial. Natasha, what will it take? What will it take for this drug to get approved in Canada? By the way, for those in the back who didn't realize, Anne and Natasha have sort of miraculously appeared after many delayed flights from two opposite poles in the weather spectrum, from Houston and Toronto, respectively.
So usually response rates in the 60+ range.
Really? Okay.
Are that then we can make the argument that this follows the path of EGFR inhibitors, ALK inhibitors, etc. I agree with you. That's a short PFS. I also agree PFS is not very helpful in a single arm study, but it's short. That's a lot of pain for not a lot of gain. So second line, I think this is very exciting, more exciting than docetaxel. But I have a question for Greg and Ann. Is there like evidence of dose response? Is this like a FATNEB where we don't need 50 or 40 and maybe 30 will do?
Or for that matter, DACO, where the lower doses after dose reduction were associated with better survival.
I think there's definitely something to that, Natasha. All the ones that I've done.
Ann, can you go to the mic a little bit?
Sorry. I definitely think there's something to that with this drug, because all my dose-reduced patients still maintained their response. So I'm wondering if maybe we just started at the wrong dose.
So Ann, you would use it frontline?
I would, but
Okay.
I've had a lot of experience with it. I'm comfortable with it, and I really like
Figure you're reserving the chemo for later.
CNS. Yeah, I really like the CNS penetration. I've actually seen some patients with multiple brain mets that prior
So the
radiated.
trial
resolved.
allowed new
Yes,
brain
but
mets.
this is not the current company sponsored. That was the phase
Okay.
1/2. Yeah.
Paul, what's your criteria?
Yeah, so second line, to me, this reminds me a lot of, Cabo in RET-positive lung cancer.
Well, it looks a little bit better than that.
Right, no, but in terms of, Greg talked about this, right? This is sort of the starting point that we have for these inhibitors. Is it an issue of just drug, right? Is there a better drug that's going to yield us some better responses? And so I think that's what I would hope for in terms of moving up to first line.
So you need an OC, well, something halfway between
better,
this and
yeah.
OC.
It doesn't have to be OC, but I think a little bit better. I mean, part of the issue, though, also is for a lot of us, this is uncharted territory. Most of us haven't given POSI yet, so that familiarity is not there, I think, to be able to make any kind of informed, at the end of the day, decision as a clinician. So I sort of reserve my judgment based on that.
Marty?
So I'd agree. I don't have personal experience, but I keep wondering, why is it that we feel compelled to repeat the mistakes of the past? I mean, we've learned with the EGFR inhibitors they don't need to be at these major doses. Here's something that's had severe disabling toxicity. Everybody who used it, 60% dose reduction. Did it occur to somebody that this is the wrong phase 2 dose? This happened with Taxotere. Even with Taxotere, they knew to back off. Let's just start lower and give it a drug that actually people can take. It's an oral drug that hopefully they'd be on for a long time. And this is craziness.
I know, it's like Suritinib.
I fully agree,
Sorry,
actually.
a horrible drug.
Yeah.
And I mean,
But it works, right?
well, it worked. Yeah, it had its moment in the sun, and that sun has set.
I'm sorry, which drug are we talking about?
Suritinib.
Oh, okay.
What of late and unlamented memory.
Wow.
No,
Horrifying.
I've been preaching this, for a long time, that maximum tolerated dose paradigm of chemotherapy has done so much disservice in this era of targeted
it's a
therapy.
leukemia, it's a heme malignancies concept that's been demonstrated to be wrong for virtually every single drug in solid tumor oncology, which includes doxorubicin, cisplatin, carboplatin, Taxol, Xeloda. I mean, there's simply no drug that is more effective at its maximum tolerated dose in solid tumor oncology. We've demonstrated this, and it's like a 30, 40-year literature, and yet we keep pushing them to the MTDs, putting them out there and saying, gee, they're getting side effects,
So
let's lower
the
dose.
general consensus is straight phase 2, don't need to compare it to chemo frontline. Include separate cohorts of first and second line and beyond. And
But why not compare to chemotherapy? I mean, since there is some, the response
well,
rates
if
seem
you're
higher,
giving
but
it
that's in
after a
single arm.
carbo-containing regimen, what do you?
Right. Oh, no, okay.
You're not going to compare it
so
to
you figure it's-
immuno or
Well, in
to-
front line, if I were going to do some front line, the key question would be like carbopem, or perhaps maybe it's time to do the studies that we probably should have done with some of these others of a brief course of carbopem followed by this drug at a tolerable dose, or even possibly combined with.
I'm going to get into that in a second with the regular EGFR mutation. Comments on TAC-788, the other drug in this space? Still too early, Greg, or?
I think it's, to me, as somebody who's used it more, and I bring the same biases that Anne brings to the POSI data, I think it's manageable. I think, I've seen the 160 is probably the full dose, and I've seen a lot of patients do extraordinarily well, even at 80. And so I think they're both, in a similar niche. I don't know that one stands out over the other, but it's way too soon to say.
So the 80 might be a threshold, and going higher may or may not be beneficial.
And of course it highlights the weird thing of that we as oncologists like to dose by meter squared on some things, but other things we just give the same size tablet to 100-pound women and 200-pound men. There might not be so much sense in that.
This seems to have a bit less grade 3, or is that just
I think
false
it's just
impression?
early. Yeah, I think it's just early. But I certainly have patients who've done well, and I certainly have patients who've done very poorly with tox.
Yeah,
So getting-
sorry,
Ann?
I sent a few patients for Bob to treat on this before we got that open. My understanding is the HER2 mutants aren't doing so well with that. Is that-
I don't think we've enrolled any. I think we might have
We
enrolled.
definitely have
one.
some here. The
Yeah,
ones that are in
some.
yellow
No,
are
I mean,
HER2.
personally, in terms of what I've seen, but
So-
yeah, the response rates.
Looks like you got a stable 2 PR and 2 PDs.
Yeah.
Yeah, my initial sense is that
3
for
PDs, yeah.
I mean, yes, this is all very limited data, but at least for the HER2 mutants, I thought that they were not thinking that this would be developed much further for HER2 at least.
Any data on failing one going to the other?
So there, in the POSI data that John's presented from time to time, he's shown some patients who were on this and then went to POSI. Now that they may very well have been, they probably were patients at very low doses early in the phase 1. So I'm not sure what to make of that.
Do we know anything about because there are a fair number of patients who've been treated at the academic centers, what the genomics are for those who did not respond or whose response was very short in terms of the NGS data for
Right.
those
Too
folks?
soon to say.
Yeah.
For TAC, I don't know.
And for
And
POSI,
for
I don't know if
POSI,
you
we've
guys.
collected it, but I don't
Okay.
think the analysis
That'd be
is,
interesting to
I know
see.
they're doing it,
Okay.
but I personally don't know where it's at.
Got it. That would be nice
So I have to
see.
confess, this is the most we've ever discussed exon 20. This meeting, frankly, any other meeting I've been at, and it's, again, we say, well, it's rare, but to be honest, it's not much rarer than ALK, maybe equally common as ALK. And
I have actually
until this has happened,
diagnosed
we
more 20 insertions
yeah.
than
Yeah.
Really? Okay.
And way more common than
Well-
BRAF, V600E.
So,
Yeah.
now let's go to the more common,
track.
19 and 21.
Let's not forget
Um,
track.
So a question has come in regarding future development. Are we just going to be content with OC and focus on quality of life? And perhaps we'll have Natasha address the first part of this. Or are we going to see a race of OC in combination with BEV or chemo, all of the NEJ trial, or metformin? I wasn't aware that that was going on. So Natasha first, QOL. Should we just rest on our laurels, or what do we do? And then Anne to address the combos.
So I think that a few domains are better on osimertinib, and I think the real strength is that you're progression-free for longer. So I think that's kind of really the maximal quality of life approach. I found ASCO a real struggle with this pull between improving survival and decreasing tolerability by adding chemotherapy to everything, whether it was IO or whether it was a TKI. And so I remain torn. Luis Pavares always says to me, if you're going to enjoy your quality of life, you have to live. So I have to accept that. And I was really quite blown away by the Japanese data and the median survival and that improvement. I was also really impressed by the rate of crossover of Japanese patients to chemotherapy after failing a TKI.
What
which
was the
is
rate? I don't recall.
70% or thereabouts, whereas in Canada it's something like 20 or 30%.
So what about a trial comparing OC, arguably the control arm, versus just 4 cycles of PEM-carbo with OC continued, or the more conventional PEM-carbo maintenance PEM with OC?
I mean, I think you could do that. The other thing you could do is you could use all the circulating DNA data that are emerging and say, people either start with OC, and if their circulating DNA goes up, you add
So a
chemo,
trial that actually
or you start
uses
with OC
data
chemo.
from the circulating DNA to control arm of OC alone or some other.
Because if someone's well controlled on OC alone, maybe
Interesting
you
thought.
don't need it until you do, and maybe finding it early is the secret to not losing people to salvage. I don't know, I mean, I think that would be what I'd prefer, but I think your ideas are also great. There's definitely some.
But I would throw out there the idea that giving a limited number of cycles of chemo plus OC, it has a certain appeal, just as it did 15 years ago when erlotinib was compared to erlotinib plus carboplatin paclitaxel in the CLGB trial. So I think, and it didn't show us
Although
some
they
great
didn't know
response.
mutations.
Yeah, but it was a never smoker trial, and but there was no.
A long time ago.
Yeah, but-
It was a different one.
In
They were
in
not
another
mutation
galaxy.
selected.
But they were 60%, 70% mutants. It was, but it didn't. There wasn't some dramatic result there. So I don't think we're going to see a dramatic result.
And combination data?
This is sort of one of those things where either you're okay with it or you really hate it. And I'm one of those people that really hates it.
Hates what?
Combination chemo
With
TKIs.
TKI.
Mhm.
Because
Quality of life, and then plus we don't
Pem-carbo is not a
know-
bad combo.
But we don't know what we're doing to the clonality, the heterogeneity. We don't know if we're selecting or adding a selection pressure that might lead towards some resistance. And that always makes me nervous. And the patients do great on a monotherapy TKI. You could always, like Natasha said, I always just bring in the chemo when they begin progressing, or I bring in the BEV if it's just minor progression. And the goal is to give them the best time for the longest period of time you can. So I tend to always veer more towards keeping them just on the monotherapy TKI for however long.
Would you
I can.
rerun the IMPRESS trial in
No.
OC failures? No?
I wouldn't. I think that those trials were run with TKIs that are not necessarily as good as OC.
Okay. Other thoughts?
Yeah, I think death is a very low quality of life. People really want to,
Unless you're on poziotinib.
That may be more of a theological.
Masters two
and I
positions
still think that I think the quality of life for most people on even carbo-pem by itself with appropriate antiemetics, which have changed over the years and are they're well tolerated. People get these drugs. I think the doses may even you could probably modify the doses a little bit and give a limited course, 4 courses. We're talking it's over within 90 days for something that patients, you look at the Japanese data, that was a pretty sizable improvement. I mean, I think people, at the very least, we should do the damn study. And because without that, we have no idea what we're arguing about. I think it's the hypothesis is there, the preliminary data is there. You're not going to kill these people with these drugs. And, I think the likelihood of a positive study greatly exceeds that of a negative study.
I agree.
Just, I don't know.
I'm not sure of that because OC is so much better than JAF. But
Are we moving on from EGFR now? Because I guess I wanted to highlight.
I want you to talk about whatever you wish.
I do think the future is combinations, but it's combination targeted therapy, right? Like, so this MET data that I showed, I think this is going to give us the hint about how we overcome MET, and then the next step is to prevent MET amplification as a mechanism of resistance and doing.
How would you know which thing to do frontline, though? I mean, you wouldn't. The problem is at what point you can't predict which
right. How do you predict which
mechanism of resistance going to exist? Would you have a separate arm looking at gefitinib for 797?
I think we're in the learning phase right now, and I think this data is showing that OC plus savolitinib is manageable and partially effective. I think that's provocative.
Is
and I think,
savolitinib better than Criz in this setting?
oh, it's way better.
Way better, okay.
I think so. So I think OC-Sav is interesting, and then I think there's a number of ongoing efforts looking at drugs like afatinib, dacomitinib, gefitinib in the context of osimertinib, whether you combine it, whether you do it sequential or alternate. And I think those ideas are interesting, and I think as we pick these apart and learn more over the next couple of years, I think the next big phase 3 trial in this context is maybe we'll start Marty's trial before that, give some chemo plus minus, or OC plus minus chemo. But the exciting stuff in 2-3 years is really going to be some combination frontline trial.
Frontline or the Natasha Leal approach monitor the blood, see what's emerging, and add it sooner than later.
No, we're not that smart.
And
It's gonna
that's
be
where
frontline.
a frontline study, again, with lots of data to collect, you know, in a modern era, you know, it's, the world has changed, and I think we could also answer the questions of clonality, because we could just as easily argue that this will start eradicating your resistant clones early on in a limited course, and you may be able to go back, but it's a perfect time to start looking and sucking away those
I
specimens.
personally would probably subscribe to, at least in more aggressive patients with higher tumor burden, the chemo OCD. I know Ann's concerns notwithstanding, obviously if somebody's older and frail and has lower metastatic burden, I'd be disinclined. A couple other questions. We really do have one more talk, which we want to get done. Nasser's been gracious to move it from tomorrow to today. Is there any role at this point for either erlotinib or afatinib or gefitinib and now dacomitinib in this setting? Greg?
I think
you live and breathe this
Right.
class of drugs.
I think this is something worth. There are clinical trials that I'll design using those drugs, but in the standard of care context, I don't see a place for them.
Natasha, what's the standard in Canada? Is it OC or that hasn't quite made its way there?
I mean, if we could afford it, I suspect that people will shift.
Uh-huh. So you're still giving erlotinib or gefitinib?
I
on
still
that?
give gefitinib, I
Huh?
have to tell you. I still give gefitinib, I'll have to tell you.
Afatinib?
I still do give gefitinib, yeah.
Gefitinib.
But I think that there's a lot of enthusiasm for osimertinib, and I think, you know, especially when you look at kind of PFS2 from FLORA, there doesn't seem to be harm in starting with a third generation TKI first. You know, patients don't seem to suffer after they progress on the initial TKI. Longer term, they still seem to be doing better. So I think that if people can afford it, I think they'll switch.
So,
Even in Canada.
you're probably the only person in the room who gives gefitinib frontline. Of course, you're
But I'm
coming-
probably the only person, apart from Greg, who could, right? Because it's always been approved in Canada, whereas you guys didn't have it, right?
That's true. It was late to the game. So there's tons of other questions, at least in our pre-plan, but I think we've really had a good discussion. I just want to know, around the room, when someone becomes TKI refractory, what's your go-to regimen? We'll start with Ann. Truly refractory. They've gone through 2 or 3. The TKIs are not going to cut the mustard anymore.
So carbopen pembro currently?
Uh-huh. So you'll do the triplet with pembro as opposed to atezo, even though we don't have
Well, I
formal data.
tried to get the Iron Power 150, and I have not gotten
You've not
insurance
succeeded yet?
clearance.
Okay. MJ?
Carbopem and never immunotherapy. I'm pretty convinced immunotherapy is useless in these patients.
Useless or useful?
Useless. So I do carbopem.
Really? Okay.
Yeah, because I mean, EGFR mutated patients, the
But what
more I
about the
read, the more
Empower
I get
150?
convinced.
I mean, of course, that was with
Oh,
Bev.
come on.
But
Empower 150, you really believe that story?
No, I don't.
so,
This is-
Greg, what's your
Especially if they
regimen?
have liver mets. then.
Right, it's the liver mets. I give platinum Pembev.
So you go back to Bev.
Yeah.
Nasser?
That's what I would do.
Natasha, what occurs in Canada?
Pem Platinum, but we put them on a lot of trials, plus or minus.
Paul, you do
I
what
work in
Greg does.
Memorial.
Huh?
I work in Memorial.
Yeah, but you don't give IO in this setting, or do you?
Unfortunately,
I do
because,
carbopenbev, yeah.
because of the way
Marty?
Memorial works, he doesn't see any patients.
I'd, give carbopem.
Pembro.
Yeah.
Okay.
I think
Interesting mix.
chemotherapy makes
So
all
I've
drugs new again.
carbopem
So I
Bev.
established very good responses.
And, but I have given somebody, first one, Empower 150. It took forever to get it approved. I mean, this was not easy. Several layers of appeals. You know, first it's all done electronically, so you get the rubber stamp rejection. Then there's a second tier and a third tier, and finally you talk to a human. And for what it's worth, I mean, maybe I shouldn't believe the data, but that hazard ratio looked
So-
pretty impressive.
So Corey, I actually think that there is a lot to the story of combining a checkpoint inhibitor with Bev or with the VEGF inhibitor. I think we've seen that in bladder. There's data in kidney. There's the Empower data. I think the challenge with Empower 150 is the Taxol.
Well, which is why we would prefer to give that. or break the Taxol into smaller doses. With that being said, Nasser, come on up. He is our last talk for the day. Nasser's going to talk about small cell. So we've gone from squamous to EGFR to small cell.
Okay. So I'm going to be talking about immunotherapy in small cell, and this is my overview. So I will look at the two FDA-approved drugs, Atezo and Nivo, a couple of drugs which are active, Rovati and lurbinectedin, and Corey wanted me to touch on some pathways as well. So this is the study that led to the FDA approval a few weeks ago of atezolizumab in combination with carbo and etoposide versus carbo, etoposide, and placebo in the first-line setting of extensive stage small cell lung cancer. This is the patient population. They did not require PD-L1 testing. Oftentimes in small cell lung cancer, you get less tissue. There's sometimes a lot of necrosis and crush artifact. So for this reason, they anticipated they would not get everybody's PD-L1 status. They didn't mandate PD-L1, and thus far they haven't reported PD-L1. But they did report tumor mutational burden, and they used two different cutoffs to consider it to be high, the cutoff of 10 or higher or 16 or higher. And you can see that, well, or maybe you can't see, but those are very well balanced between the two groups. And this is the response rate, duration of response between the two groups. And you can see that the response rate was actually slightly higher in the placebo group. So carbo, etoposide, atezo did not actually improve the response rate compared to the same with placebo. In terms of the percentage of patients who progressed, it was 10% in the atezo group versus 7% in the placebo group. So this, if you had just seen this, you would have actually been convinced you were going to see nothing else and nothing to the story. And this is the overall survival on top and the progression-free survival on the bottom. And the progression-free survival is also fairly unimpressive. You can see the curves rapidly fall, and they get down to about 10% very quickly. That would not have been encouraging either. This kind of looks like the chemo immunotherapy data in non-small cell for the PD-L1 less than 1% population. So not a very impressive PFS. In fact, the median PFS is pretty much the same, but the curves do slightly separate. But there is an overall survival advantage, and it is meaningful. The curves, there's not really a nice plateau at the tail of the curve, but you can see at 1 year, the difference is about 14%. And going from 38 to 51, 52% is a big deal. And this is what led to its FDA approval. In terms of side effects, the good news is there really wasn't a whole lot of additional side effects when you add atezo to carbo-etoposide versus just giving a placebo. The one sort of cautionary note about adverse events in small cell is that patients with small cell do tend to have a higher incidence of paraneoplastic syndromes. And they can be dangerous paraneoplastic syndromes. They can sometimes be life-threatening SIADH, or they can be neurologic paraneoplastic syndromes like cerebellar ataxia and Lambert-Eaton syndrome. And these can be very, very difficult and life-threatening side effects. Patients with Eaton-Lambert syndrome can easily end up on a ventilator. But they didn't really report any difference in those types of side effects, but I wonder as this becomes more generalizable if we'll be seeing more. And I have seen 2 patients now with immunotherapy-induced myasthenia gravis.
Yeah, I think in the appendix in small print, they have 1 case of GBS.
Of
In
which?
the atezo arm.
Guillain-Barré?
Guillain-Barré.
Guillain-Barré. Yeah. Okay, so that takes care of atezo in the first-line setting, and nivolumab is actually also FDA approved in the third-line setting after 2 prior chemo regimens, and it's really based upon the CheckMate 032 trial, which is really a study of Nivo or Nivo-Ipi in this patient population. And you can see the spider plots. If you go down, you're shrinking tumors, and you can see whether it's Nivo or Nivo-IPI. You do see about 20% of patients do get responses. And the good news is about 2/3 or so of the patients who do get a response have a response that lasts at least 9 to 12 months. So it's not a high response rate, but it does tend to be durable responses. And what we had seen with earlier data is patients who had high tumor mutational burden had a higher likelihood of responding to these drugs. With pembrolizumab, those with high PD-L1 scores also had higher response rates, about 35% versus about 5% if they had low PD-L1. But the FDA approval for nivolumab in the third-line setting is regardless of TMB and regardless of PD-L1. Nivo-IPI is also listed in the NCCN guidelines, but only Nivo alone is FDA approved in the third-line setting. And these are PFS and OS curves that are just comparing different dosages of Nivo-IPI. This is not a comparator to a chemo control arm or a placebo control arm. Now, we did see a press release regarding this study. This is Checkmate 331, which is nivolumab versus chemotherapy in patients with relapsed small cell lung cancer. So these are patients who had advanced disease, who had all received chemotherapy and were progressing. Despite that, they had a good performance status. Their primary endpoint was overall survival. And they were randomized 1-to-1 to Nivo or chemo. And if you were in the United States, the chemo was topotecan. And if you were outside the United States, you could get amrubicin or topotecan. Amrubicin is approved in Japan, but not in the United States. And about 4 weeks ago, we saw this press release that BMS announces the phase 3 trial does not meet the primary endpoint of overall survival with Opdivo versus chemo. So I don't know what this means. I think largely atezolizumab's first-line indication makes nivolumab's third-line indication probably fairly meaningless, but I don't know if they'll keep the third-line indication or not. We'll see. Okay.
And then there was also a European study, right, that I think it looked at Nivo versus chemo and miserable outcomes for.
Is that a phase 3?
Yeah,
thought
no,
this
randomized
was-
phase 2.
Oh.
Yeah.
I didn't see. Have they reported
This
those
is reported at ESMO.
negative?
Yeah,
That's not good.
dramatically negative.
Yeah, it's bad.
You can't beat topotecan.
Yeah.
That's what we were saying.
You got problems.
Yeah.
It's a dog of a drug. Well, we haven't done a good job beating it. That's the problem.
That's, it's a low bar if we're not meeting it.
Okay, so we'll talk about Rova-T, which is an antibody drug conjugate targeting DLL3, which is fairly specific for small cell lung cancer. About 80% of patients with small cell have some expression of DLL3, and about 1/3 to 1/2 of patients have very high level of expression of DLL3. So you hook up an antibody to DLL3 with a anti-cancer drug, usually a mitotic spindle poison, and then you test it in these patients, and this is really the antibody drug conjugate. And this was a phase 2 single-arm trial called Trinity. That was the registration trial that was planned to get this drug approved. It was a single arm. All patients got Rova-T every 6 weeks times 2 treatments, and they could go on and get more at the physician's discretion, but it was designed as every 6 weeks times 2, and the primary endpoint was response rate. And the drug is active. In the waterfall plot, clearly active, and I put patients on this trial, and it has kind of unique side effects. You can get pleural effusions and pericardial effusions. You can get these funky rashes that almost look like burns. Variety of other interesting antibody-mediated toxicity. So it's not a friendly or easy drug, but it is an active drug. And it was particularly active in the high DLL3 expressors. This is the interesting side effect profile that I mentioned, the photosensitivity reactions, the third spacing, pericardial and pleural effusions, etc. And in March 22nd, 2018, here was the press release from AbbVie basically saying that they are not seeking an accelerated approval based upon this data, but that their phase 3 trial will continue. And so that study, I believe, is still continuing. This is an interesting drug, lurbinectedin, and this comes from the ocean. The company that makes this has a number of products, marine products that come from the ocean. This inhibits RNA polymerase II. This drug is structurally similar to trabectedin. Trabectedin is actually FDA approved to treat patients with liposarcoma and leiomyosarcoma. And it is an active drug in small cell lung cancer, and it's not trivial activity either. So one study of 68 patients who had received 1 or 2 prior lines of therapy had a nearly 40% confirmed response rate, although the median progression-free survival is only 4 months, and the median survival time was about a year. And the most common side effect was myelosuppression, including thrombocytopenia, and the FDA did grant it orphan drug status. There is combination data with lurbinectedin and doxorubicin, and a 67% response rate in second-line small cell that was reported, but only in 21 patients, with a lot of grade 4 neutropenia. So I don't know the feasibility of this in our small cell population. But the last bullet point there is their registration trial, and this is a global trial. It's called Atlantis, and it's a phase 3 trial of lurbinectedin with doxorubicin versus CAV or topotecan after platinum-based therapy. And then Corey asked me to talk a little bit on the FB4 receptor tyrosine kinase, which I have to confess I knew nothing about and had to do my own literature search. And what I found is that this is basically concepts, and I think first in human drugs. I don't know, is anybody here doing a study in this? Yeah. So apparently this target is overexpressed threefold in lung tumors compared to normal paired normal tissue, and its overexpression promotes proliferation, colony formation, and motility. And if you inhibit it, it reduces those things. And there is positive tumor responses with mouse xenografts with single target strategy. And in combination with paclitaxel, there was this animal data that showed responses. So I think this is a ways off, but I believe there is a drug, a first-in-human study for that. I was also asked to talk about MET inhibition in small cell lung cancer. And MET signaling is active in chemo-resistant small cell cancer cell lines. And if you inhibit that, at least in vitro, it seems to have some effects on inhibiting downstream signaling that's important in cellular proliferation and overcoming chemo resistance. And then another pathway, which I have to confess I knew absolutely nothing about and had to... You're familiar with this, Max?
I'll make fun of my boss for a second. If you've heard Charlie Rudin speak in the last 2 years, you've learned about Schlafen 11.
Schlafen?
S and MSKCC stands for.
Okay, I think I have. Now that you bring that up, that does sound familiar. So I will leave it to Greg then to expand on the Schlaf 11 axis. So this is apparently seen in chemo-resistant cancers, and if you silence this, you can modify the effector protein, and you can potentially overcome resistance in small cell models. And I think there may be a drug, a first-in-human drug for this one too.
Actually, wasn't it in Taufik's paper, the ECOG study, I think with sunitinib, that actually that was the marker?
Yeah,
It's in
and
the JCO paper.
Yeah, and from Charlie's lab, they showed it in resistance to platinum etoposide.
Everyone knows about Schlieffen.
Schliffen?
Schlafen
Schlafen.
means to
It
fall
sounds-
asleep
it sounds
in
like
German.
a German
Schlafen,
secret.
get Schlafen, you
Yeah,
go to sleep.
Schlieffen 11. Ach, of course you know about Schlieffen 11. How could you not?
I'll correct my comment about a randomized trial in Europe. It wasn't nivolumab, it was atezolizumab. And they reported at ESMO, and dramatically, atezo was
Atezo
worse than
versus
chemo.
But it sort of
In what
confirms
line?
the
Second line,
the
second
press
line,
release, yeah.
Yeah,
So,
and this is.
and remember the response rate for, that's what I was looking it up while Nasser was giving the talk, and I couldn't find it. So what were the results? You're looking at it right now.
Yeah, atezo versus topotecan, the hazard ratio is 2.26 for PFS,
Favoring
Whoa.
topo.
favoring topotecan. It's
What was the
dramatic.
response rate for Atezo?
I don't have that.
Well,
Was there a response rate for
The
Atezo?
PFS curve for Atezo, according to this, is basically
It's a double
It's like
diamond.
it's a
like
double diamond.
Yeah, it's a double.
So I mean, Nevo alone wasn't that bad, but it was still a 10% drug, which is not too different from just about anything else in this setting.
Yeah.
So why, I mean, in the randomized phase 2, the Ipi-Nevo data did look a little bit better.
I wonder if you also have to, I think, select patients with Nevo and with Pembro. You know, if you don't have high TMB or high PD-L1 expression, the activity was very, very, I mean, it was like 5%.
Yeah.
Well, I have a very small 12-patient experience with Ipi-Nivo second line.
12?
12,
That's pretty good for small cell.
yeah.
That's a big experience.
That's in last 2
And-
years. And most of them did horribly, but 4 of them did well. 3 of whom, amazingly, are on holiday for various toxicities, and one of them
Totally
is,
on holiday, or they're on sort of like an attenuated
No,
every so
tot-
often Nevo regimen?
no, total holiday, and one is 1 year out, one is 10 months out, which I'd never
So
seen.
who else has used Ipi-Nevo in this setting? Everybody.
I have. That was horrible, but
Horrible.
Nivo alone, so I don't have a vast experience, but it's sort of the same, it's sort of similar, is that most of the patients, I think, whether, Nivo or Nivo-Ipi, seem to do horribly, and then you have this occasional, like,
Well, it's
they're
more than
back from,
occasional, it may be 1 in 5 or 1 in 6.
that have
It's
a lot
not-
of, that get toxicity, you stop the drug, you figure
Well, you
you'll never
stop
see them
the
again,
Ipi.
and they keep coming back to clinic 6 months later, you
Yeah.
know? I've had exactly that.
Paul,
Still
similar
alive 2
experience?
years after they came
Yeah,
out
I
of
mean,
study.
it
It's
hews to
impossible.
sort of the data that's been presented in terms of responses. I had some people who responded quite nicely to it. The Pembro data and the PD-L1 expressors looks
You kn-
decent also.
This kind of reminds me back in like 2001 when we were all using Aressa. And, we'd sit around tables like this and say, boy, that drug sucks, but I have this one patient. And everybody had that one patient.
And me
And,
again?
clearly
I
we just don't
turned it
know what the
off.
biomarker is.
I think Nair Rizvi is doing a study, I shouldn't say a trial, where he wants tissue from these super responders or patients who have done well. Maybe we should all make an effort to send him tissue. I will actually.
So what is the secret sauce to the responders? I mean, I have one too. Horrible toxicity. Couldn't get the 4th dose of Ipian. I think her husband would have shot me. And she was willing to soldier on, but PS went from 1 to about 3.5. And then off the Ipi, she recouped her disease. Frankly, she responded far better to Ipi-Nivo than she did to original chemo.
Yeah.
And I just saw her last week. She's well over a year out. I still have her on Nevo. I mean, whether I should or not, but she's very reluctant to stop that. And her PS is 0. Her disease is 98% gone. It's really quite amazing.
Yeah, these are the patients whose immune system doesn't forget who the enemy is, stays
So-
awake after the wake-up call.
The problem is they're sufficiently in the minority that the maintenance trial or probably upfront trials will be negative despite the existence of it. Maybe not. I mean, if the tail on the curve can carry the day, they might prove positive. But I worry that we've all seen these patients. They're rare, but they occur. They're incredibly grateful considering what they have. Natasha, you've seen similar.
I would say it's about 10 to 15% of these patients, right? I mean, those are the response rates in unselected patients,
Right.
and that's the whole thing. We have
Well,
to figure out how to select them better. So is it PDL-1 composite score, or the, you know, the
Uh-huh.
combined proportion score? Is it tissue TMB as opposed to blood TMB?
Mm-hmm.
I mean, we need to do, or is it, you know, immune cell landscape? We need to do a much better job. And all of these unselected trials, I mean, they're going to sink an approach that is really magical for 10 to 15% of these patients.
And you've seen similar.
I did. You know, I actually had one lady who even had brain mets, and with Ipi/Nivo, everything went away, and she had a CR. Unfortunately, she then got encephalitis
From the
So-
NEVA, or from something.
from something.
Had she gotten prior PCI or brain radiation?
She did,
So that might be a concern there.
yeah.
So, okay, we've seen the similar phenomena. Is everybody using the 133 regimen up front now?
What do you
MJ?
mean?
It's the Atezo with chemo.
Well, I haven't had a patient since the
Oh,
approval.
right, you have more EGFR than small cell.
Yes,
in
I
your
do.
neck of the woods. Greg?
But is anybody excited?
I'm sure you have more EGFR than small cell,
Yeah.
and you're the
So I think-
niche at Memorial.
Yeah, everybody's going to do it, but the question is anybody excited about it, right?
So
Does anybody
are
think?
you
"Oh,
excited about it?
No, I'm not excited about it, but
Because we're jaded now. We're used to hazard ratios of 0.5 and 0.6 and advanced non-small cell, and this is like
but, you know,
an old hazard ratio of
Master took us through the
0.8.
data.
Or
There
0.7
was
it
no
0.7 or
improvement in
0.8?
response rates. The PFS curves are like right next to each other. Oh, but there was a difference in OS.
And what happens to the second line Ipi/Nivo or Pembro response? Like, what happens to that? You know,
And remember the third line. It
Yeah.
couldn't get it at the second line.
so, yeah.
It couldn't be topo TKI. Now, I think we need to see the actual data because you wonder how many patients crossed over, and is that why it couldn't be topo TKI?
But that would be the first time we have a good trial where they really did cross over,
Yeah,
right?
but
You know,
who
'cause-
knows? You know, I mean, so I would
Yeah,
like
there
to
was
see
a
the
day
results.
where this would have been very impressive. Granted, it's
15
you know,
years ago, it would be very impressive.
I mean, there would have been a plenary session at, not
2003.
during the lung plenary, but at the main
Yeah.
plenary at ASCO.
Well, yeah. This still
So-
might have made it there. Yeah.
So several of my colleagues at ECOG are worried about the apparent drop-off. Is it just too early, or you share that concern?
I think this is an early look, too.
Too early, well, early enough that we
Those
don't
curves
really
may
know.
come together a bit.
So Natasha, is this approved in Canada yet or not?
It's not, and I think the only challenge they're gonna have is this whole, now we expect much more of our drugs, so.
Because we've
if
been,
we-
so if
jaded
by
You
the
go back 15
non-small
years,
cell data.
this is great, this is like erlotinib and BR21, right? So why wouldn't they approve it?
Well, that had an approval for about 10 years, right?
That's right. And so, you know, my statistician said, when I discussed this, she said, you know, we would never let you leave the building with fewer than 10 patients in that survival curve. She said, we'd truncate it right there. She said, I'd never
So
let
you
you
feel that
present it
was a
down to the last
premature
one."
reporting of the OS?
Either that, or they're in big trouble if those curves do come together, but it's
Uh-huh.
early.
Yeah.
Paul, you routinely doing this, or you're?
Yeah, I mean, insofar as, you know, I routinely see first-line small cell patients.
You don't see too many.
Which, yeah, you know, Charlie and now Vicky see most of them.
Marty, yes, no?
Yeah, I mean, I haven't had the opportunity yet to use it. I would do it. Am I excited? You know, I think it's more than that. I think that this was the group we really, you know, small cell forever disappoints. You know.
How many years have we been looking for something?
We've always felt that this was like that next big curable disease, and certainly when you have this hypothesis that the hypermutated tumor should be the one to get it, here's a tumor that we know when it stimulates its own immunity, you know, because the patients who do get the autoimmune complications have always tended to do better, that it should, you know, in many respects, this should have been the cancer that really got a blast out of immunotherapy. I think that's why people are disappointed. It just doesn't seem to have done as much as one would have thought. Hard to know
But it's
why.
done more than any predecessor has ever done.
Which ain't saying much.
So one of the
But no,
quest-
actually, etoposide was much better, you know? I
Wow.
mean, as a single agent, it's still, I'll bet etoposide would blow away any of these drugs one-on-one.
Right, and you still have to wait for the keynote trial, right?
for the,
The
The keynote
study.
trial.
well,
yeah.
the similar trials.
Yeah, and Pembro's been better than Atezo
Yeah.
at every
Well, this will
step.
be the
Yes.
proof in the pudding.
We'll
If it's,
see.
it occurs across different diseases, then maybe I'll be a true believer. Is any concerns about the fact that Atezo has been, it's in the NCCN guidelines now, but it's not yet FDA approved for this, or I don't know.
No, Atezo's FDA approved.
FDA, so,
Yeah.
okay. So what,
You could
the
get it
questioner was
easily.
asking about that, okay.
You could easily get it by insurance.
What was the day of the approval?
Very
It's pretty
recently.
recent, right?
Yeah, in the last, I would say, 4
Okay.
weeks.
So, Atezo, chemo, assuming you put people on that, then what, when they progress? Topotecan in your hat.
Not given topotecan in like 15 years. I do.
I only do it on clinical trial. I can't think of
I
a
will
time
tell
I've
you
done
the-
it voluntarily off the trial.
So the phase 3 study with dinutuximab versus.
Which, I'm sorry?
Dinutuximab irinotecan versus topotecan has completed worldwide accrual of
That's right.
about
Marty's
500-600
the
patients.
Uh-huh.
And we will one day, not too long in the future, know the results.
Well, we still have, there's the NEHRU study, which I think you may have mentioned, Nasser, or maybe not, which is the Rova-T in the maintenance setting. And we still have the small cell data of Ipi-Nivo, again, maintenance, I guess, or Nivo versus placebo.
I thought the
And the
maintenance
same-
was on hold, that study.
Huh?
I thought the maintenance trial was on hold.
NEHRU?
Yeah.
For Rova-T, as far as I know, it's still ongoing. I don't, does anybody know otherwise? Across town, Jefferson, they have that trial open. So, what else? What's happening in your shop for small cell?
Well, aren't you guys doing Ipi-Nivo Rova-T?
Yeah, there's
Ipi-Nivo
the-
Rova-T?
Yeah,
Yeah.
there's
Well,
the-
Holy
Charlie's
moly.
doing it.
Charlie's doing it. It's the nuclear option.
That reminds me of Tom Lynch's iced
And
tea.
you have patients that are living to tell the tale?
I don't know. I've never referred anyone. And,
Really?
yeah, and with the approval of Atezo,
I
no,
thought
don't
I
know
had
what's gonna
chutzpah,
happen.
but boy,
Yeah,
that's...
I know.
Or
Our,
cojones may be the
our
right
NPs
word.
are always worried when someone, says, "Hey, let's consider this." They're like, "I don't know about that."
Charlie's behind this?
Yeah, Charlie's involved in this.
Well, he has to be involved with small cell.
We've got a couple of trials. One is Ipi-Nivo plinabilin.
Which one? I'm sorry.
Plinabilin.
Uh-huh,
And then the other is a PARP inhibitor with carbo.
okay.
Yeah, we're doing a couple of PARP inhibitor
PARP
studies,
inhibitors.
olaparib,
Stuff is
and
gonna be
yeah,
interesting.
yeah.
What's happening north of the border, Natasha? In second-line small cell? Or is it high-dose prayer and low-dose prednisone?
Yeah. I mean, I think most of what we're doing is sort of things initiated outside. We're doing
PARP
some
inhibition, yeah, that's tough.
tissue-intense studies of immunotherapy, in particular Nivo-Ipi. And then there is a lot of interest in PARP inhibitors and radiotherapy with or without checkpoint inhibitors. So we have Schlafen-11
Yeah,
disciple.
that was where the PARP, I
Schlafen-11
misspoke. It
dis-
was not sunitinib, it was the Schlafen-11, that was Taufik's paper in the ECOG study with the
Yeah.
PARP inhibitor.
So
And
Ben
the
Locke
Schlafen-11.
works with us now, and so he's very interested in putting something together where there's radiation IO and perhaps
So
PARP
it's
inhibitors.
the inhibitor combined with what? With topo or with something else? Or is this a front
On
line?
its own with PARP.
I'm sorry?
With a PARP inhibitor on its own and
Really?
radiotherapy. That's not up and going. But
Yeah, we have a durva, olaparib, and then we've done a lot of the lurbinectedin trials in our
Uh-huh.
phase 1 group. So we've sent quite a few small cells that way. And then we inhibitors also.
So, a question again regarding TMB. Remember in that secondary analysis of 032, high TMB seemed to do really well. Has anybody seen further correlation with that and with Ipi-Nivo? I mean, certainly that's a road that needs to be looked at. And Natasha, you mentioned other potential markers, or at least the need to look for other markers. Anything else to add about small cell? What about
Oh,
limited
can I-
disease? Are we ready for IO combined with chemo-rads in the curative setting?
We've been doing it.
Yeah, we have a trial
Uh-huh.
we are about to
Easy.
open.
With which IO? Atezo?
Pembroke.
Pembro.
Yeah.
And I know you've got something at MD Anderson with,
Yeah, we've been doing Pembro.
yeah. And Energy's going to be doing something along those lines as well. What's happening in Canada with limited stage?
nothing yet. We might join the NRG trial.
Energy trial, okay.
Energy.
Asper, you've got something going on at Hog, I'm sure.
No.
No, really? You can
It's-
join the energy trial.
Yeah.
Two questions that were left over from before. This goes back to the whole issue of path. How do you decide whether to use IR or IP? So interventional pulmonary versus interventional radiology. We'll just go around the room. Is there a preference? Do you default to one or the other? Or,
For biopsy?
yeah.
Just whatever their anatomy is, if they're easily
So
accessible
whatever's
by
available.
EBUS.
Obviously, if it's a
Yeah.
liver met, it's going to be IR.
Location,
Right.
location, location.
Location dictates everything. Nasser?
Yeah, exactly.
Natasha, is there a preferential service?
So we
for
do a lot
biopsies?
of interventional pulmonology, and we have easier access. So it's always a toss-up. The med-oncs prefer transthoracic biopsies, but we work with Kazuya Yasufuku, who, so anatomy doesn't seem to matter. He can get anywhere in the lung
So he
with
can get a
his
needle, a
19-inch
core
laryngoscope.
biopsy from any organ?
Pretty
anywhere?
much, pretty much.
And he's an IR person?
He's an interventional pulmonologist.
Oh.
He's a surgeon, yeah.
But then he can only do it in the lung, unless he's branched out.
Well, they do some EUS as well, so they can get down quite low.
So he's a pulmonologist who does.
He's a thoracic surgeon, so then when something bad happens, he can fix it, yes.
Okay. Our IP people will not do EUS.
He does.
We have to cross-refer them to the GI folks.
Our GI people won't let them do EUS.
Yeah, there's a lot of territoriality around here. Paul, what's
This is
the
the IR preferential unless there's a reason.
IR
Yeah.
preferentially? What's happening at Fox Chase?
What's the
IR versus IP.
Oh, individually.
Oh, Ann's response was location, 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 so was NJ.
Depends,
Depends,
it's
right.
anatomy,
So we tend to preferentially use IP if it comes to sort of an equal situation, simply because A, they're much more responsive, they're much more cooperative. They're as, I think it was you, MJ, that said that, they do enough passes with the
Yeah.
needle that we're always getting
Yeah, no,
more than
they do.
enough tissue. They're very clued into our need for, to maximize specimens. And then there's only a limited number of IR people, and it's like the day of the week.
And you work with
like the flip for our institution.
The pulmonary people we're working with all the time, the IR is sort of different.
And then, Anne, there was, Ignacio couldn't make it, he's stuck in Paris. I guess there are worse places to be stuck. But I gave his talk earlier before you came, and we've been very creative about how to do all this. And you guys seem to have some sort of IO-based study where you're getting blood and tissue and then repeating it through the course of the treatment. And so he said over 800 patients have been enrolled in this, mostly IO, more than 1,000 tissue biopsies. You collect at least 2 second biopsies during treatment. Kay Posset, what's happening with all of this, or you're just continuing to collect the data, or has it been reported yet?
So I'm not sure, so we have like a ton of these banking protocols, so I'm not sure which one this one is, or if it's with the spore.
Uh-huh,
So if it's with the spore, there are specific things that they're looking for.
uh-huh.
And if it's one of the banking protocols, though, then those specimens, part of them can be reserved for other analysis. So I'm not sure which one this is.
This one, it had liquid biopsy, it had tissue,
Yeah.
it had both cytologies and biopsies, and it was pretty
Yeah.
comprehensive.
Yeah, so it sounds like it's one of our banking protocols.
And then I had asked him also about his frank thoughts about TMB. Of course, we're going to discuss this a lot more tomorrow, but I figured while I had him. And I think the adjective lukewarm would sort of describe his feelings about it.
I think the difficulty is how, the validation of TMB, like which platform should we be using and what's the correct one?
The 2 Memorial people left. I thought maybe
I
they
know.
would give us the pro TM. Well, they'll be back tomorrow, and we can hear all about why we should be doing TMB. Any other comments about small cell?
Oh, maybe just for the people developing drugs in the back of the room, often we'll get these single-agent epigenetic modifiers as second-line or third-line small cell
You
studies.
want to give them with something else.
Yes, please, because it's just so frustrating. You put everyone on, there's this huge gap in need, and then there are these agents, and they all cause thrombocytopenia, and then they don't move forward. So I would rather see them in combination than as single
Than
agents,
just
or at least to
single agent.
run in and then quickly move to something useful.
Okay.
That's what
So I think we're done for today. We're actually only 12 minutes behind, amazingly, considering we started about 15, 20 minutes late. I thank you all. This has been wonderful, your unfiltered thoughts. And I think we're going to, we have about a 30-minute break. For those who are going to dinner, we're going to convene, is it the lobby or the bottom? The bottom. Down the escalators, or the down escalators, as my grandson calls it. And meet there, about 15 minutes on the hour. And we'll walk over. For those who find it's too cold, you can take a cab. It'll probably take twice as long, though, given the traffic and everything. But so we'll convene there in half an hour. And again, thank you all. It's been wonderful.